serikali kuilinda, na tujenge taifa letu. Ndio wajibu wetu, Kenya istahili heshima, tuungane mikono pamoja kazini, kila siku tuwe na shukrani.
Linda Mama imenisaidia hapo kutoka clinic. From clinic nikaendelea kukuja clinic nikajifungua through CS na sijalipa pesa hata moja.
In 2013, Kenya introduced a free maternity policy in all public healthcare facilities. In 2016, the Ministry of Health shifted responsibility for the program, now called Linda Mama, to the National Hospital Insurance Fund, NHIF, and expanded access beyond public sector. However, beneficiaries did not access some services and out-of-pocket payments were still being incurred. Health facilities in most counties lost financial autonomy and had no access to reimbursements from NHIF for services rendered. Fund disbursements from NHIF are also characterized by delays and unpredictability. Under the Strategic Purchasing for Primary Healthcare SP4PHC project, ThinkWell collaborated with the county governments of Isiolo, Kilifi and Makueni to review the implementation of Linda Mama and offered technical support to overcome the associated challenges.
In Kenya, the Strategic Purchasing for Primary Healthcare project employs 4 strategies. The first is to support strategic purchasing for primary healthcare at county level with a focus on expanding counties' participation in the Linda Mama program.
When we look at the insurance coverage, it's still quite low at around 19%, with private sector insurance taking around 2%. And as we move to UHC, this is one of the areas that the government want to address. So we've had programs since 2012-2013 of covering the poor households, of covering the orphans and vulnerable children households through the National Hospital Insurance Fund. We know now that it has changed to National Health Insurance Fund. We've had other programs like Linda Mama, covering that group of women, pregnant women and their newborns up to 1 year. Another program that has been successful also towards UHC. And lessons from those ones really are informing us towards moving toward social health insurance.
We identified Linda Mama as one area that has been hugely underutilized and a lot of money has been left on the table. We immediately embarked in collaboration with NHIF local branch and the leadership in the sector to see how we are going to claim and benefit from the funds that is domiciled with NHIF.
ThinkWell became that necessary link between the NHIF office and the health department. That link was actually missing because those meetings were handled there. Through those meetings, we've been able to do something.
Linda Mama was an area that was almost phased off, but when ThinkWell came on board and emphasized on these monies that were being lost, revenues that we should have had to address minor maternal and child health concerns easily, but we were not even collecting those funds. So when that was brought to clear attention of the administration for health, it was important that we incorporate Linda Mama data, that is for claims and what has been received, all into our monthly meetings in order to strengthen further claims processing processes.
Linda Mama has been a game changer in our community from a different spectrum. We have seen the numbers of skilled deliveries improve from below 50% just about 2 years ago, and now we are at 83%. Also, we are improving on the other indices like the maternal mortalities, the neonatal mortalities. We've seen those also reduced, which again, within the framework of Linda Mama, we can directly attribute that to the program.
Linda Mama imesaidia sana inawezesha kina mama wasikose huduma, hasa kama za ujauzito, kwa kliniki ya ujauzito, kujifungua. Anapokuja hapa, bora amepata ile namba ya Linda Mama, anajua ya kwamba hakuna pesa zozote zile ambazo ataweza kutozwa. Ile pesa tunapoipata, kuna mambo mengi ambayo tunafanyia hapa. Saa nyingine hata kuna dawa kidogo kidogo zile ambazo tunakosa, tunatumia ile pesa. Pesa ile pia inatusaidia kuweza kufikia wale wateja wetu kule kwa community, kuweza kuwafikia na ujumbe wa afya.
I joined the facility back in 2019, and I think by then that's when Linda Mama started rolling its work in the county and in the country at large. We've seen a great improvement in the number that deliver in our facility. That has also increased our revenue. Because you see, in 2019 alone, we had 3,335 deliveries. So assuming all were paying through Linda Mama, each is 5,000, that's a good amount of money. So we've seen also reduced home deliveries. We've made aware our community through the use of the community health units, such that they know if I go to a facility and I'm expectant, I can get the services using Linda Mama.
Right now we are using Linda Mama, which is funded by the National Ministry through NHIF. We are able to see mothers who have maternity-related issues. That one covers admissions which are related to maternity. It covers also cesarean sections, normal deliveries, newborn admissions, also the clinics, the antenatal and the postnatal clinics.
We believe that Linda Mama is one such good scheme that NHIF can be able to use to entrench or to mainstream the application of strategic purchasing, which is a key intervention as we move towards universal health coverage.
I'm so pleased to see you all here today. Samburu Washiko, the regional representative at the Bill and Melinda Gates Foundation, Dr. Salim and Dr. Maina from the Ministry of Health, Dr. Amara from the Council of Governors, Matt Boxshon, I always struggle with that one, the project director, county directors of health here present. I see the leadership of the Kenya Healthcare Federation, partners, ladies and gentlemen, good morning. I'm really delighted to see you all here today. As I look around, I see many familiar faces. And for us, really, it's a day to pause and reflect on the latest evidence about financing for primary healthcare. We're looking at both the progress that the country has achieved, but also looking at challenges and areas that we still need to address. And my team today are looking forward to sharing and discussing information, insights and lessons from the strategic purchasing for primary healthcare project. This is a project that we've been implementing for the past 5 years. The project is an investment by the Bill and Melinda Gates Foundation that aims to improve how governments purchase primary healthcare, with a focus on family planning, maternal, newborn, and childhood. ThinkWell has been working in collaboration with government institutions and local research partners. So here in Kenya, for example, we've been working with the Kenya Wellcome Trust. And the project is in 5 countries. So that's Burkina Faso, and we have Marizonia with us, in Uganda as well, Indonesia, the Philippines, and Kenya. Here in Kenya, we have been working with 4 county governments. So that's the county government of Makueni, that's represented here today, Kilifi, Isiolo, and most recently, Kakamega. But before we dive into the key themes emerging from the project about purchasing and financing primary healthcare, I'd like to start with the basics. What is purchasing and why is it important? When we talk about purchasing is not about procurement as we know it, but purchasing is really one of the 3 healthcare financing functions that is concerned with how pooled resources are allocated to providers. And making purchasing more strategic is about ensuring that those decisions about allocation of funds to providers are linked to information about the health needs of the population, provider performance, outputs, and outcomes. And the point of making purchasing more strategic is to ensure that we are getting the maximum value out of our limited resources. In the Kenyan context, we have several agencies that play the role of purchaser. We tend to focus a lot on NHIF, which is both understandable and justified. They are one of the leading purchasers. But increasingly, counties control the bulk of funds for service delivery, and especially for primary healthcare. And then we also have the Ministry of Health that is implementing some national programs such as the Linda Mama program, the Edu Afya program, and others. Are these agencies working with the right types of providers? Are they covering high priority services? Are they paying providers to maximize health outcomes? These are the points that are the core of strategic purchasing. These are the questions that we try to address and answer when we talk about strategic purchasing. Strategic purchasing in Kenya is recognized as a key reform for universal health coverage, and that is outlined in various documents such as the UHC strategy. Kenya has made great progress towards its universal healthcare coverage journey and in instituting various healthcare financing reforms. As we all know, universal health coverage is one of the government's big four agenda. Primary healthcare is at the cornerstone of universal health coverage. The government has developed the policy framework for UHC implementation. We have the UHC strategy. There are various strategies, the primary healthcare policy and strategy that were launched the other day by Dr. Salim's team. And since devolution, we've also seen many countries and counties expand geographical access to healthcare, especially by increasing access to healthcare by constructing a number of health facilities. Primary healthcare has also benefited from the introduction of the free maternity program that we call Linda Mama, that is now managed by NHIF. The Linda Mama Fund is of about 4 billion shillings annually and is channeled via NHIF to reimburse facilities for deliveries and perinatal services. I have visited many facilities across the entire country, and I can say with certainty that Linda Mama works. There are, of course, challenges, but Linda Mama works. Linda Mama has increased the coverage of skilled delivery across various counties. Another win for UHC and primary healthcare has been the removal of user fees at level 2 and 3 facilities. The national government instituted a grant called the User Fee for All Grant, which seeks to reimburse level 2 and 3 facilities for user fees forgone. The government has chosen NHIF, the National Health Insurance Fund, as a vehicle for the UHC program. And NHIF has been very busy instituting various reforms over the past few years. In 2015, for example, NHIF shifted from a historical focus on hospitalization to an expanded benefit package that included outpatient care. It also introduced capitation, a population-based provider payment mechanism, which is the cornerstone for financing primary healthcare in many countries. But despite all this progress in advancing primary healthcare, there are still some challenges that require addressing. For example, financing of primary healthcare, and in particular level 2 and 3 facilities that offer the bulk of primary healthcare services. From the work that we've conducted in a number of counties, we see that very little funds go to level 2 and 3 facilities compared to the funds that go to level 4 and 5 facilities. So for example, we see over 80% of resources at county level going to level 4 and 5 facilities, which are often less than 5% of the health facilities in a county. The other challenge that we are seeing is that there is a fee for goal conditional grant that I talked about that has been going to level 2 and 3 facilities was recently discontinued. So what really are the plans to continue financing primary healthcare? I think these are the questions that we really need to think through. One of the other challenges that we've also seen in our work is that in many counties, facilities lack financial autonomy. And we'll see much more about this as my colleagues present various presentations. What this means is that health facilities cannot retain resources that they raise from various sources, such as from NHIF, from user fees, that's level 4 and 5 facilities. And therefore, all these funds go to the county revenue fund, and facilities therefore have very little incentive to continue raising these revenues and to improve service delivery. The other challenge that we also see is that there's limited participation by a number of counties in national programs, such as the Linda Mama program. In some counties, we find that some health facilities have never ever received any Linda Mama funds, have never participated in the Linda Mama program or the Edu Afya program. Yet these are programs that have been running for over 5 years, by the national government. The facilities still continue to provide maternal and child health services, but by the lack of resources to improve service delivery. And so, the question that we are wondering is, will it take these facilities in these counties another 7 years, 10 years to benefit from the UHC program that is being rolled out right now by the national government, if it's taken over 6 years to participate in the Linda Mama program? So looking forward, as Kenya continues to combat the COVID pandemic and face a double burden of disease, of both communicable and non-communicable diseases, financing primary healthcare is even more important and should be the key priority for government at both national and county level. The government's plans to roll out the primary care networks is a great opportunity for strengthening primary healthcare. But as we strengthen primary healthcare and scale up the UHC program, there are still some questions that we need to address. For critical health financing reforms that have proved successful, for example, enabling facilities to have autonomy, how can we scale this to all counties to ensure that all counties are benefiting from resources from the UHC program? How can purchasers such as counties and NHIF send signals to provide us to improve quality? How can the same resources going out to health facilities do much more? Basically, how can we buy much more health from the same resources that are going to health facilities? How can we track financing levels and expenditure at facility level to ensure that with increased autonomy, we also see increased or improved accountability of resources? How do we purchase community health services? Community health services are a key component of primary health care. And how can we purchase services from innovative primary healthcare service delivery models, such as telemedicine, that has become quite important, especially in the COVID pandemic? Our facilities participating in the UHC program that was launched earlier this year by His Excellency the President, are beneficiaries aware of the benefits that they're entitled to? We may not have all the answers to these questions right now, but I believe that if we all pull together, we will. ThinkWell is committed to continue working with the Ministry of Health, the Council of Governors, and other partners to actualize Kenya's universal healthcare vision. Supporting countries in their journey towards universal health coverage is really at the center of what we do. We are currently in discussions with the Bill and Melinda Gates Foundation to continue the work that we've been carrying out so far for the next 4 years. I'd like to thank the Ministry of Health, the Council of Governors, the various counties here present for their collaboration and leadership in implementing this project. And finally, I'd like to thank the Bill and Melinda Gates Foundation for the investment in Kenya's health system and in Kenya's UHC journey. Asante sana. At this point, I'd like to welcome my boss, Matt Boxall, to provide some remarks. Matt is the project director of the strategic planning purchasing for primary healthcare project.
Thank you, Anne. And thank you, everybody. Anne promised not to do this to me until I got off the plane this morning, and has now asked me to step apart. So, thank you, Anne, for inviting me to this wonderful thing. We will talk later about putting me on the stage to speak. Anne has mentioned several times that I am her new boss. And I want to challenge that a little bit, because I don't think I really am. I think on paper I am. But we will see. I've been involved in this project for a while, actually. And I see Samburu and Nirmala sitting here in front of us, and I do remember hatching some of these initial plans, sitting in a cafe, I think we could probably put an exact date on it, because as we drove to that meeting, we heard the news that Donald Trump had been elected. So 2016, I think. Do you remember, guys? We sat there drinking coffee, talking about strategic purchasing for primary care, and also thinking, what is happening in the US? So it's been a while, and through most of that time, the leadership of the project has been with Nirmala, who's hardly been mentioned, but has done an amazing job pulling together programs across 5 countries and supporting people like Anne and her team to come up and give you the help and support, that analytical background that is so useful as you make policies that can deliver the services that are needed to those most in need, using strategic purchasing as that tool. We are in discussion now with the Bill and Melinda Gates Foundation about continuing this work in Kenya and in other countries for 4 more years. But we are not planning to continue working in exactly the same way. And whilst I have the honour and the privilege to carry the title of Program Director at the moment, that really is a moment of stewardship and transfer of the leadership of this project to the young women that we see in this room, our country directors, Anne, Marijan, Angela, and colleagues in other countries, in the Philippines, in Indonesia, and we hope in Pakistan. And my role is not to lead them, but to support them as they take on the leadership of this project. And for the next phase of strategic purchasing for primary care, we will be working together as a team with leadership coming from Kenya and from Uganda and from Burkina Faso, not coming from me in London. My role will be a supporting role. And one of the things we're going to be doing over the next couple of days is talking through what that looks like and how we can make that happen. So after Anne and her team have shared with you and discussed the amazing work that you have all been doing in Kenya, we will go off and sit together and talk about what managing a project like this in partnership with KEMRI and our other learning partners, in partnership with Bill and Melinda, but with real leadership and responsibility from the country directors, not from somebody sitting in Portugal. So that's my plan here. That's the challenge that we're setting ourselves over the next 4 years of the project. So Anne, don't say that I'm your boss, because I'm not going to be very much longer. More likely you're going to be my boss and telling me how I can help. I think that's a good plan, don't you? I hope so. Thank you.
Thank you very much, Matt. I wish all bosses would speak the same way.
Colleagues, friends, and partners, a very warm good morning to you all. Good morning. That did not sound resounding at all. And you promised me for some coffee at the beginning of the morning. Let me start by thanking Anne for this really warm invitation to participate in what is truly an important symposium. For those in the audience, and there might be a number of you who haven't had the opportunity to meet me and interact, my name is Saburu Washiko, and I serve as the regional representative of the Bill and Melinda Gates Foundation, covering our East Africa region. I cover our work in Kenya, Tanzania, and Uganda, as well as Rwanda, and there are also a number of other line engagement countries that we have in the region that fall under my remit. It truly is a pleasure to be here today among so many friends. I have since, as you heard, relocated to the southern part of this continent, and it's not always every day that I have the chance to join you. So when I do get this opportunity, I embrace it, and it's truly a pleasure to be here with you all today. Before I go too far along in my remarks, I wanted to deploy that very helpful catch-all phrase, all protocols observed. I always find that expression really, really useful because they're always important members of the audience you don't wish to offend, and there are also other members of the audience who think they're important and shouldn't be offended. And so I always lead with all protocols up just to make sure that we have all bases covered. But on a more serious note, allow me to first recognize a number of truly important friends and partners that we have here today, either physically with us in the room or virtually, because I'm aware there were arrangements that were being made to have some of our distinguished guests join us virtually. I wanted to start with Dr. Mercy Mwangangi, who is known quite well to this community. And Dr. Mercy, as we know, is one of the country's big forces behind health financing, health economics, and we're truly honored to have somebody like Dr. Mercy as a champion for this work. And I think the country is also very lucky to have women of substance like Dr. Mercy occupying the position that she does. Dr. Salim, it's a pleasure to see you again after a very long time. Dr. Maina, huge pleasure to see you as well. Thank you for the really strong roles that you play as champions for our PhD work, UHC work in the country. I don't know if Dr. Wangari Nama is with us. I now see her sat at the back trying to be very discreet and quiet, fully exposed. Dr. Wangari, it's a pleasure to have you here with us. UHC advisor at the Office of the President, who together with Dr. Mwangangi and others in the ministry and outside have truly been the brains behind Kenya's very ambitious UHC program. I recognize our colleagues from the Council of Governors as well as colleagues from our county governments. Recognize you for many reasons, but mainly because you have the unenviable task of translating the ambitious programs and goals that are crafted by our colleagues such as Dr. Wangari into very tangible, practical, concrete programs at county level and even at sub-county level. And we know in the context of Kenya, which is a federated environment, that the rubber truly hits the road at county level and at sub-county level in terms of delivery of health services. And so it's really, really important that our county colleagues and the COG walk this journey with us, because without your consistent engagement, your assistant support, this work will not be possible. Our friends from ThinkWell, led by Matt, who refuses the title of the boss. Matt, it's great to see you. Again, Nimala, of course, we've walked a very, very long journey with you, and it's appropriate that you be duly recognized for the work that you have done. And you've been my sister in crime. It's a pleasure to see you again. And our colleagues, of course, from Burkina Faso and Uganda, and the rest of the ThinkWell team. Truly, it is a pleasure. Allow me to begin by recalling how exciting it's been to see the government of Kenya prioritizing strengthening primary health care service as an important strategy to achieve the goal of UHC. The goal of ensuring access to quality healthcare for all is a sacrosanct constitutional aspiration. I think many of us in the room would know this. And it's perhaps not surprising to see His Excellency the President having included UHC as part of his Big Four agenda. This approach of improving PHC as a necessary prerequisite to attaining UHC is deeply aligned with the Gates Foundation's philosophy in healthcare broadly. And it's been really rewarding and quite invigorating actually to collaborate with the government of Kenya and many of our grantees in making this work possible. I wanted to provide some context for the Foundation's work in Kenya and on the continent as well, particularly as it pertains to our work in healthcare. So the Gates Foundation has a very long track record of engagement in Kenya, spanning over 15 years and cutting across many social sectors. The Foundation, for those who aren't aware, has 34 different strategies across our agriculture work, our health work, gender, financial inclusion, and global education portfolios. And over 25 of those strategies have Kenya as a focus country or Kenya as an important country of interest. The Foundation's leadership at the very highest level of our co-chairs, presidents of some of these divisions I just referenced, have visited Kenya on countless occasions to learn more about the work that we support in country and to connect with many of the stakeholders that we work with. As many of you know, the Foundation, as one of the leading philanthropic entities globally, rarely actually implements this work directly. We rely on very strongly on partners such as ThinkWell and many other partners represented in this audience, including our partners, Kemri as an example, but we also rely very strongly on our government partners to implement the work that we fund. And so, in the last 2 months, as an example, the president of our Global Development Division, Dr. Chris Elias, was here in Nairobi. And UHC featured very, very prominently in the conversation that he would have had with Dr. Mongaldi's boss, following the theme around bosses. The CS for Health, Mutai Kagwe. And our leadership has always viewed Kenya as a really important, trailblazing, exemplar country where we have a very enabling political environment. We have a very strong ecosystem of implementing partners, such as ThinkWell, and a very healthy appetite for testing out new ideas. My sense is that this partnership with Kenya, a very dynamic partnership, will endure and in fact grow in both breadth and depth. Throughout our very long journey of partnership with Kenya, health has obviously been a very core priority sector for the Foundation. Earlier this year, our health systems team finalized the Foundation's new PHC strategy, which is comprised of 2 core pillars. Under the first pillar, we'll prioritize investments that accelerate country-level foundational reforms through a linked progression across financing, supplies, HRH, and data, building on the political will I just made reference to transform access to PHC. The second pillar seeks to promote innovative service delivery models, leveraging technology and new modalities of care in countries seeking to enable better PHC access. And I'm really, really delighted that yet again, Kenya is a core priority country for this new PHC strategy. In addition, the Foundation is also committed to further leveraging global financing levers, such as Gavi, the Global Fund, and the Global Financing Facility, GFF, to scale proven tools and approaches and use advocacy to push for transformational reforms at the local, national, and global levels. This emphasis on global financing mechanisms or our global levers, don't think it's going to be a surprise to many in the audience, just given how important a player the Gates Foundation is in financing some of these global facilities. We've remained big contributors to the so-called 3Gs, and in fact, as we lead in the lead up to the replenishment of the Global Fund, the Gates Foundation is yet again stepping up to support both the global fund but also mobilize really important partners in ensuring that we have a very, very strong global fund that can respond to the needs across the 3 disease areas that we cover. Understanding and addressing key health systems barriers is critical for formulating appropriate interventions that are catalytic to improving PHC. One of the essential building blocks of a well-performing health system is, of course, the financing pillar. Evidence has shown that low government spending on PHC results in high out-of-pocket spending, low utilization, and poor health outcomes. The recently concluded National Health Accounts shows that PHC expenditure in Kenya has increased in absolute terms from about 245 billion Kenyan shillings in 2016-17 to 285 billion Kenyan shillings in the year 2020-2021. However, the proportion of PHC spending to total health expenditure has reduced by 10% in the same period, pointing to the fact that the health system is not increasing PHC spending at a commensurate rate with the increase in health expenditure. Another challenge is the ineffective allocation of resources due to funding fragmentation, inadequate flexibility at the facility level to use resources as per local needs, and poor visibility of expenditures. Anne made a really, really good job of tracking some of these challenges and how they show up at county level and at sub-county level when you don't have what's referred to as facility autonomy. To address some of these challenges in PHC financing, the Gates Foundation will continue working with implementing partners to co-create high-impact, context-specific, fit-for-purpose solutions with governments to, number one, reform financing fundamentals, including increasing spending on PHC and paying for PHC more effectively. Number two, strengthen mechanisms to move funds from the central level to the local level. And three, ensure that frontline providers have the ability to use funds to source inputs. And four, invest in data systems to inform operations and strengthen accountability. And again, that last point is not going to be a surprise to many in the audience who are familiar with the work of the Foundation, because data, evidence-based, and strong data systems tend to be almost like the beginning point, the starting point, and the building block for a lot of the work that we do. For the past 5 years, the Foundation has supported ThinkWell to implement the strategic purchasing for primary healthcare, it's a mouthful, project to strengthen how the government purchases primary healthcare services with a focus on family planning, MNCH, in 5 countries, including Kenya. In collaboration with MOH, the COG, NHIF, county governments, the ThinkWell team in Kenya has been pursuing a program of work that combines strategies at the national and county levels to improve how public funds are used to pay for PHC services. I'm therefore delighted to be here today to listen, to learn, to discuss successes with you where successes have been registered, but to also explore with you areas of existing challenges that still need to be tackled and the key opportunities we have to strengthen PHC from this work as we strive to build a future where every Kenyan has access to quality healthcare without suffering financial hardship. Truly appreciate the invitation to be here with you, and thank you so much to everyone for having prioritized being here this morning. Thank you.
I wasn't being too close to the room. But it's a pleasure to talk to you this morning. Yesterday, it's about 10 years of devolution in Kenya, and yesterday we were just looking at different outcomes and how they have changed. And one of our colleagues noted that if you look at some of the outcomes from a health perspective in Kenya and what we've made in the past 10 years, you realize, especially by comparing Kenya to other neighboring countries and countries that are of similar contexts, that we probably have made a change that is unusual
in terms of improvements. And a lot of time when we sit back to talk about and think about challenges, we forget that we might be living in an opportunity time where Kenya has made significant changes, probably changes in the past 10 years more than what we made in the last 100 years preceding that period. 50 years under the colonial government and 50 years of self-rule. So as we sit here today, I do hope that we look at all these things in perspective, the positives, the negatives, the opportunities, and the threats, so that we can emerge as a country better, stronger than ever, and draw that path that other countries, other communities around the world can follow. So thank you very much. It's a pleasure. County and national government officials present here, executives of various agencies and companies, representatives of development partners. Very good pleasure to have you, Samburu Washika, with the Gates Foundation. Indeed, the Council of Governors have done a lot of things jointly because of working together with the Gates Foundation and exchange meeting today. And join you all in this room to reflect upon how to strengthen purchasing for primary health care in the context of universal health coverage. As we know, universal health coverage is a big priority for both the national and county governments, and one of the president's big four agenda, which really is meant to transform the lives of Kenyans. I would like to thank ThinkWell for creating this learning platform, because it is by collectively learning from each other and sharing knowledge, ideas, unique innovations and strategies that we can achieve universal health coverage and achieve good health for the people and communities that we serve. As you are all aware, health is an evolved function in Kenya. Actually, one of the biggest evolved functions together with agriculture. As such, initiatives like this one seek to improve the efficiency, effectiveness, and affordability of health services to the Kenyan people remain priority to county governments. Like in many countries, Kenya seeks to identify the best method to engage and pay healthcare providers, because this is a key cog in improving access to high quality services to all. Ladies and gentlemen, in recent decades, Kenya's population has rapidly grown, the life expectancy has improved, and an aging population has started to emerge, despite the fact that the majority of Kenyans still remain youthful under the age of 35. The disease profile has also transformed rapidly, from a context where communicable diseases comprised a majority of priority diseases to a new norm where communicable diseases, non-communicable diseases, and injury all pose a big strain and concern to our health system. The prevalence of chronic lifelong conditions continues to increase. All these are critical pointers to Kenya that we need to prioritize and rethink our investments in primary health, including classical primary health and preventive interventions. Otherwise, we will not be able to achieve universal health coverage. Studies have shown that contexts like this, a failure to invest adequately in primary health is likely to cause unsustainable increases in health costs. With most counties already investing about 30% of their budgets to health, despite having 14 evolved functions, and with continuous emerging needs for further investment in healthcare, and the continuous reducing and dynamics around donor funding, it is time for us as Kenya to make a paradigm shift in health investments and ensure more elaborate investments go to primary health. We know that early investment in effective prevention would enhance good population health, reduce morbidity and mortality, including from lifelong chronic illnesses, thus saving resources for both the health system as well as social services. Ladies and gentlemen, we know that a shilling invested in primary health has been found to save about 5 in direct medical costs and up to about 11 shillings on overall cost if we consider the potential losses, like for example, individual productivity and caretaker costs. For most of our communities, you know, when somebody is hospitalized, it's not just one person that you put out of the labor market, but rather you have caretakers that are also put out of the labor market to stay with them in the hospital, to cater for them. And all this is a cost. As such, county governments highly prioritize primary health and are fully on board when it comes to discussions like what we are having here today. And indeed we have, as the Council of Governors, been part of this discussion with the Gates Foundation and ThinkWell, and also been part of other broader purchasing discussions, like the ones around NHIF, so that we can ensure that we have NHIF that is a strategic purchaser, but also county governments and other purchasers that are responsive to the needs of the people. We've also have had discussions around ring-fencing of health funds in different ways, including a number of counties now adopting facility improvement funds to be able to ensure that the resources generated at facility level can be reinvested. Ladies and gentlemen, making health purchasing strategic involves basing purchasing decisions on information about provider behavior as well as population health needs in order to improve health system performance in terms of equitable access, quality of care, and financial protection. We are all aware that evolution has fundamentally restructured health financing arrangement in Kenya, including making county governments the main purchasers of primary health services, which are most often delivered at community and health facility level. This makes county governments the backbone for achievement of universal health coverage in Kenya. I am aware that strategic purchasing of primary healthcare project, that the strategic purchasing for primary healthcare project in Kenya has strengthened county governments of Isiolo, Makueni, Kilifi, and Kakamega, and enabled them to allocate resources to health facilities and manage their performance in the context of Linda Mama, the UHC program, and the Transforming Health System project. By targeting these 4 counties and doing a deep dive in the stated areas of concern, the project has offered opportunities to the 4 counties to clarify and address existing gaps. This learning exchange meeting, therefore, should provide a platform for county governments to collaborate and learn on one hand, but also to shape discussions with national government and other stakeholders on policy. As you know, policy really needs to be informed by practice, so that some of these experiences and discussions we have here have their way in shaping policy to ensure that we are efficient, effective, and actually achieve the objectives that we want in the health system. Finally, ladies and gentlemen, the Council of Governors encourages continued involvement and partnerships with the national government, development partners, private sector actors, and other stakeholders in order to achieve UHC. County governments remain fully committed to fulfilling the requirements provided by the Constitution of Kenya that guarantees all citizens the right to affordable and accessible quality health care. We know that this is both a noble and huge task. We want to serve our citizens in the best way possible style, with goodwill, clear ambition and strong commitment, working together, we surely will positively transform the lives of our people. Thank you very much. God bless you.
You have to account for resources that are coming from the exchequer and all that, and ensure everybody gets these services according to a certain policy standard. But on the other hand, the purchaser has shifted in a significant way. I think for me that's the balance I'm trying to find in the discussion.
Thank you. Any other question?
Thank you for the presentation. My name is Kenneth Mashari. I'm the country representative for Options. Very good presentations that you provided. Just picking up on what Dr. Isabel presented, and I know the focus is on return on investment in terms of what's going in and what's actually coming out. But I'm curious, and just following on from that question that was asked just now, how do we finance this? Because we don't have enough resources. And I'm just curious as to where we have other ideas on how to actually finance the NHIF to do all the things that it's trying to do. I don't know if any thought has gone into that. I know there's the aspect of being paid back for service delivery, but that's not sustainable, right? So if we really want to scale and then have the impact where we want to get to, we need additional resources. So I'm just curious to find out if there's any thinking on that. Thank you.
Yeah, thank you. Good morning. My name is Anastasia Mita from Kenya Healthcare Federation as a CEO. I think I see the opportunity in terms of claims and digitization, and especially the fact that now NHIF is mandatory. From the ThinkWell and other stakeholders, how do we champion digitization across the board as far as NHIF is concerned? What that means is that even if I'm going to the pharmacy or to the lab or I'm being seen by the clinician, just like the private health insurance model works, then the money is deducted or at the point of service, not necessarily. I don't know whether now the challenge is because a lot of it is manual or what. How do we get to full digitization so that even if I go to the facility, whether private or public, with my NHIF card in whatever form that it will take, then that facility, that point of contact, my reimbursement automatically goes to the central NHIF. What that means is that you won't have any challenges with transparency. You won't have any challenges with non-claims. So it all remains a matter of look at the central whatever and put the money where it belongs. Now, what that is also going to do is that for those facilities that are giving, preferred by the patient, the money follows the patient. So you won't have any county or hospital boundaries for the patient. The patient will choose. It means then that the facilities will be very competitive in terms of really following the money. So that even as we implement and enforce the FIF legislation, then there is also a benefit for and a motivation for the facilities to actually improve on the service that they do. Whether it's public or private, I come from private sector, but for me is a dream where the money follows the patient, where the service is best preferred for the patient and nearest to the patient. Thank you. So I'm hoping that we can actually get to that and work with NHIF to achieve that dream because it's achievable and it is the best way to go. Thank you.
Oh, okay. Don't you want to?
Eventually we have to. Thanks. My name is John Kimutia. I work with the International Development Partnership, Kenya. I think there was something very interesting that Dr. Isabel presented, which shows the proportion of health financing that is now coming from government, from the mid 30% to over 50% in about 4 years, which is pretty significant. But that then means that the role that the public finance system is playing in health financing also has increased. And it would be good to hear from Felix and Boniface on what the other actors in that space might be doing to the conversations that we're talking about in the county assemblies, the National Assembly, the Commission on Revenue Allocation now has a formula that decides how much money, the basket that goes to counties. But even the public, for those of us who are on the public finance side of things, we are pushing a lot for these participatory budgeting mechanisms, which means citizens now are having a bigger say in how the allocations are playing out in the budget. So it will be good to hear about the level of understanding and appreciation of these other actors, and also probably the impact, if any, they are having in pushing for strategic budgeting. Thank you.
I wanted to bring out some things. I'm one of the managers. I'm a medical superintendent to a level 4 facility from Kilifi. So what we've been seeing is that as a public facility, we need to change our attitude and the way we structure ourselves, because that is the main problem. So in our facility, we've decided to take a more business-oriented model so that we go more for output financing. We only budget with what we get, because currently there's a percentage, it's around 72% of what we generate as a hospital, which remains in the facility through what we call the Health Services Improvement Fund. So for me, I think we need to think out of the box, because NHIF and whatever they are giving is not enough. So we've been calling for more innovation and thinking out of the box. So as a facility, we've been looking at it in two ways. Number one, we look at what we get, and we look at the revenue as a pot. And we also need to look at efficiencies in how we use the money we get. So we cut down on inefficiencies, we increase revenue. So the best way of looking at it is to look at other particular revenue areas where we can get more money. Most of the hospitals are thinking just about NHIF. There are other ways of raising money. How many of us have even considered doing home clinics, home visits to those who are at home? We can even look at hospitals can become income generating by also entering into other things. You can get an oxygen filling pump, start selling oxygen to private companies. You can also go for, like in our case, we've engaged insurance companies like for the teachers, Kenya Defense Forces, they're also bringing in money. There's also the Eduafia, which is also bringing in money. There are so many memorandums of understanding you can have with various companies providing healthcare and emergency services. And all this is going to increase revenue collection. For me, NHIF is just part of the revenue source, but we do not depend on NHIF. And in fact, in our facility, we've made the NHIF become a whole department. We have NHIF clerks, cleaning clerks, who we pay our own money from the facility using what we generate. We've set them up in the maternity, Linda Mama, in the wards, you see. We've spread them everywhere. We've bought computers, we've invested heavily in claiming. We have a team of around 10. We even have data clerks whose work is to take the claims and do what is called data validation. For the rejected claims, they go through another process. So through that, we've been able to actually get incomes which are very high. Like 60% of what we are getting is coming from Lindawan. The other 40% comes from other avenues of revenue. So I just wanted us to look at things from a different perspective. NHIF is not going to be the only way we are going to solve this issue. We also need to explore other ways of gaining revenue. We need to be very creative and look at the context in which our societies and the communities where we are, the hospitals are, how they work. So for me, I think that is the way to go. And I'm already implementing some of these things and I'm seeing the benefits.
Thank you so much. Thank you so much, Daktari. So we have a couple of questions. We have one on the public financing bit, health financing. We have one on digitization. We have one public participation. And I think his was more of a comment on what innovations facilities can do. Can I throw in one? It's a very quick one. It's on if I'm a mother and I have to attend the 4 clinics. So the first 2 I attend them at Kilifi County Referral. The next 2 I go to Malindi
county hospital. So who gets the Linda Mama payment? Thank you.
The restrictions of where you get the services become narrower, but then there is still more to be done so that there can be access by all the parties, particularly facilities on this online system, and they can be able to learn and understand what they need to do about it. But it does definitely remove a lot of hard work, a lot of paperwork that has been a barrier towards facilities again claiming and participating. In terms of funding NHIF, the ministry had done some calculations earlier. I hope I put this figure the correct way and them. But I think if we were to fund premiums for the entire population in Kenya, we would have used 84 billion. Roughly there. Okay? If we were to fund all the households, and irrespective of their income status, then that would be about 84 billion. And the current UNC pilot is about 6.5 billion. So the reason why NHIF becomes an important player is that increasingly government needs to keep exploring ways of paying for populations. Because the truth is, if we just say that people are going to pay for the need to have insurance, we will never achieve universal health coverage. And so government must keep looking for ways of mobilizing resources to pay NHIF premiums on behalf of populations, and then encourage the systems, public and private, to participate in that NHIF scheme so that then we have better use of those resources. One of the good things about doing that is it helps to sort of defray. Sometimes we have this big health problem that becomes a procurement problem. I don't know whether it makes sense when I say that. So, for example, we have a problem with HRH. It becomes a focus, and then all the attention moves away to HRH, and then we forget we needed to buy medicine. But you see, if you now put if you put money in a scheme like the NHIF, then you begin to pay facilities directly. Then you're beginning to break down these big procurement problems to the health facility. And that way, facilities then can begin to respond to those needs in a more strategic manner, depending on the signals that purchasers then can be able to send to them. In terms of actors, the CRA, the county assembly, the national assembly, they still need to engage these actors more appropriately. The reason why is that when we look at the national assembly and the county assembly, sometimes health is treated as a procurement concern. And so the real fight for resources for health is so that we can get a procurement deal. The key thing is we need to encourage our county assemblies and our national assemblies to be able to put these resources in pools that can be able to help increase coverage, and that coverage then can be able to be exchanged for health services delivery, and the health facility autonomy comes in, and you see how all this is connected. Let me allow Felix to also respond to it.
Okay, for me it's two things. Dr. Nelka's question on digitalizing NHIF, I think the implementation process has progressed a bit. I know the challenge is ensuring we have the requisite infrastructure within the rural facilities dominated from the claim system, which now should make claims more efficient, better visualization of the claims and so on. So I think there's need to keep on focusing on how we ensure that the claim system actually works safely. Number two, the question of financing NHIF. I know also there was a mention that it's now mandatory to be an NHIF member to pay premiums. The question is, how do we enforce within the informal sector? Well, folks like me who are salaried will have their asalo annexed to contribute. The question is, how do we ensure informal sector folks also are contributing as they are trying to contribute? Finally, the question of public participation. I know different countries have different sheets. For example, Makueni has a very aggressive public participation mechanism that includes people for facilities, but still there are weak links that needs to be strengthened. And another dynamic that I'm talking about is the health facility committees. They are supposed to be like the oversight or within that local level to ensure funds are being used prudently. How do we ensure they have the capacity to actually ensure that they understand the budgets, they understand the work plans, and they contribute? Because these are guys from the communities, and some of them may not have such skills. And also ensuring that we select them in a manner that is not partisan and independent, and they're able to provide oversight. That is a big question that I think we have to discuss moving forward. Thank you.
Okay, so I think my colleagues have addressed all the questions, but maybe just to highlight one or two things. One is on the autonomy, and my concern is the definition of autonomy. Because as we've been discussing on health facility autonomies with different stakeholders, there has been mixed feelings, depending on which stakeholder you're talking about. If you go to the government
frameworks, so we have frameworks that define the quality of care, but which remains unimplemented. Even though, for example, it envisions the NHIF to panel providers based on the KKMH score, but this hasn't been implemented yet. Another opportunity is leveraging on the star rating, where providers will be star rated on sort of 5 stars, starting from 50% and above. And this is planned to be made public. So as a user, I'll be able to vote with my feet to see which providers providing better quality care. And then there's an opportunity to leverage the data that we're generating and available databases such as HS2 to inform decision making. And lastly on that is, of course, plans are underway to shift from input-based financing to output-based financing. And this presents an opportunity to directly link the quality aspect with the purchasing arrangements. So finally, as I conclude, there's a need to move from policies on paper to implementation, because this is the biggest gap. We have very good policies on what we need to do, where we need to go, but largely these remain on paper and they are not implemented. So as a call to all of us, we need to ask ourselves, how best can we move from coming up with very good policies and arrangements, but we fail on the implementation stage. Both financial and financial purchasing incentives can be leveraged, so as the other speakers are talking about. So for example, in financial incentives using contracts or licenses to send the right signals to providers can be leveraged. But for the financial incentives, then we need to clear some of the bottlenecks, such as the PFMA Act, and how facilities could gain more autonomy to using finances. Lastly, we need to continue this conversation around how best we can link purchasing to quality, because we all agree that UHC is a journey, and quality of care being a key component of UHC, we need to continue this discussion and find for ways best to leverage on the lessons along the way to ensure that we incorporate and achieve better quality care. Related to UHC, so, and this is to the Ministry of Health, so as we are rolling out UHC, what quality assessment or quality measurement system have we put into place, and how have we linked this to, the purchasing arrangements? Thank you.
Purposively, and in each counties we went to 4 facilities, 3 public facilities and 1 faith-based or private. We interviewed national level stakeholders, developmental partners, and county officials, healthcare providers, as well as mothers receiving receiving the care at the facilities. We collected data through in-depth interviews, patient exit questionnaires, and document reviews, and did qualitative and quantitative analysis. So in terms of implementation fidelity, we find that according to the program was intended to benefit all Kenyan pregnant women and their newborns for a period of 1 year. And in practice, the program was open to all Kenyan pregnant women. However, priority was given to those without any health insurance. And in the sampled UHC pilot county, at the time of data collection, there was lack of clarity on whether the program was to continue alongside the UHC pilot. In terms of the policy, this is what the benefit package was stated to offer. So different services from ANC delivery to postnatal care, emergency referrals, complications and conditions related during pregnancy, and the care for the infant for the 1 year that the mother was enrolled in the program. In actual practice, we found that in the 3 counties, some facilities did not cover for newborn care as stipulated in the benefit package, and it was deemed that the benefit package was not comprehensive as it didn't cover for some essential services. So as can be seen in these 2 quotes, one NHIF clerk at the public hospital says that in the beginning, the mothers were using ultrasound. Later, the NHIF office communicated that it doesn't stand for it. Also, for example, when the baby gets sick, maybe 1 month, 2 months after birth, I think Linda Mama should cover for that instead of paying cash. For us, we are charging them. Another medical superintendent says anti-D medication was not covered in the program. In terms of the service providers, according to the policy, all public facilities that were previously offering MCH services in 2013 were to be contracted by NHIF, and the private and faith-based facilities were first to be accredited and then contracted to offer these services. And as of March 2018, about 6,000 public facilities were offering Linda Mama and 458 private and faith-based facilities. So in the sampled 20 facilities that we went to, we found a variation in how Linda Mama was being offered. So counties A and C, across all the types and levels of facility, starting from the health centers to the public hospitals and to the faith-based facilities, they were offering free maternal care and claiming for Linda Mama. Counties C and D, the lower level facilities, although they were offering, county B, D, and E, the lower level facilities, although they were offering free maternity care, they were not claiming for these services. Either there was lack of training or there was lack of knowledge. County D was claiming for deliveries but not ANC and PNC. County B was an exception at the time. The public health center that we went to did not have knowledge on how to lodge Linda Mama claims at the time. The 2 public hospitals, one had been offering free maternity services, but once the UHC pilot started, they stopped claiming. The other one had challenges with reimbursement, so they thought that they shouldn't claim. And the faith-based facility also had challenges in getting the funds from NHIF, so they stopped offering the Linda Mama services. In terms of the payment arrangements, according to the policy, the health facilities were to be reimbursed based on the quantity of services they provided. For ANC, PNC, and delivery, it was through case-based rates. And for inpatient services other than deliveries, it was to be reimbursed based on fee for service, based on agreed upon rebates. And according to the implementation manual, transport for emergency referrals were also to be reimbursed. In actual practice, the payment rates were reimbursed in line with policy, with the exception of ambulance service reimbursements. And across the sample facilities, the payment rates were deemed to be insufficient to cover of services, and a lot of the healthcare providers were not clear on how the payment rates were obtained. In terms of funding flows, as has been mentioned by the previous speakers, some counties had no funds to Linda Mama funds, as it was redirected to the County Revenue Fund. As you can see, counties A and D at the top, once they received money from NHIF, the public hospital had to redirect it to the CRF. County B at the time did not have facility bank accounts, so NHIF would directly pay the public hospitals by sending the money to the CRF. And County C and D had the autonomy to spend funds, as NHIF sent the money directly to their accounts. So we found that the facilities that had access to these funds were able to use it to improve MCH service delivery. Payment disbursements were to be made timely within 30 days of receiving the claims. In practice, the healthcare providers were not clear on the intended frequencies across the 5 counties, and there were delays in reimbursements, as well as an unpredictability in timing and amounts received, and these delays negatively affected service delivery. So as we can see across the 5 counties, in blue for the period July 2018 to March 2019 are the total claims lodged, in gray are the paid claims at the time, and in red are the pending claims. So the pending claims ranged from about 1% in County B to about 16% in County A. And as you can see, at the time, County B had was claiming very lowly compared to the other counties. In terms of the sources of funds, so from the sampled mothers at the time in the facilities, we sought to see who was incurring for those costs. So we found that in orange, Linda Mama was the main source of funds, reimbursing for those services. However, of importance is that out-of-pocket payments were still being made by some mothers, and that ranged from about 9% in County B to about 52% in County A. In gray as well, we've stated it as facility incurs costs. So in some cases, the mothers were receiving care, but they were not getting reimbursed from any sources. So that was also happening in some facilities. In terms of claims process experience, we found that NHIF expected facilities to make e-claims and attach the necessary documents. However, they were flexible to accept manual claims, especially for some rural facilities who may not have had computers. However, there were several challenges identified with the claim process in the counties. So this quote, I think, summarizes it well, but basically some of the challenges that were brought out is with the e-claim, sometimes it could hang, and facilities would not be able to log onto the system at the time. There was a lack of hardware in the facilities. There was a large staff turnover, and the staff trained to claim would then leave with the knowledge. There was also staff shortage, and in some cases, there was a lack of skill or, to do the actual claims. So we highlighted a few potential intervention areas from the first phase of the study. As has been mentioned before, issues to address funding flow and to ensure that Linda Mama funds are accessible to public facilities, communication of the policy in terms of investing in improving community awareness, and at the time in UHC counties, and I guess as UHC is being scaled up, clear communication on what Linda Mama looks like alongside UHC implementation. In terms of the benefit package, there was a recommendation to review and expand the benefit package to cover on some essential services like ultrasounds, to stop user fee collection for mothers seeking maternal care services, to address issues with the claim process and payment disbursements, such as ensuring facilities have the necessary hardware, are trained, the e-claim system is stable and functional, to address disbursement delays, as well as to ensure that the MCH services are well costed to ensure adequate reimbursements. So then this work has been published and is available online in terms of a journal as well as a policy brief for more information. So we went back to disseminate the findings through a one-day workshop in each county, and the focus of that workshop was to co-produce action plans based on prioritized challenges. So county officials, healthcare workers, and NHIF officials prioritized to work on specific challenges. Then we went back to evaluate the update of those findings based on the agreed upon action points. So that phase 2 was a qualitative study, and we went back to 3 of the 5 counties and did interviews and analyzed the work. In terms of the results, we found that, so for instance, County B, the county officials in County B prioritized to address the legal framework so that they ensure that there is access to funds as well as staff capacity development. So the actionable solution that was agreed upon at the end of the workshop was to follow up on the FIF bill to support revenue collection as well as to train key technical staff. And when we went back a year later, we found that there was a regulation that was passed by the county assembly to support revenue collection, and the facility and county staff were trained on Linda Mama claims and processing. In County C, the county officials prioritized addressing challenges in the claim process through support supervision by county and assessment of health facilities. And the progress at the time was there were designated accountants to every sub-county to assist in the claims, as well as routine reconciliation and reporting of Linda Mama claims that escalated to the county. County C, the NHIF branch offices sought to address the limited benefit package challenge through communicating with MOH on the benefit package limitation. And at the time of data collection, there was some engagement, but there was no perceived outcomes then. So in conclusion, we found that there was value in using a participatory research approach, as there was evidence of implementation of actionable solutions. And although these solutions were implemented, progress was not uniform across and within counties. And for the solutions that were implemented, the main perceived outcome was an increase in claims. And what was key was ensuring that there's sustained engagement between the different stakeholders. So that's the county, NHIF, and facilities to maintain the gains. We also noted that this approach was useful in highlighting some challenges faced with the Linda Mama program and engaging with counties to develop actionable solutions that were deemed feasible by the counties. However, we also noticed that some challenges still persisted, most of which were highlighted in the phase 1, such as lack of sufficient infrastructure, high staff turnover, and delayed reimbursements. So that's the end of my presentation. Thank you.
Thank you very much, Stacey, and thanks to the EVI team for sorting that out. I'll now hand over to Dr. Wangari to just put these thoughts together on reflections around the topic at hand. Thank you.
Who is the provider at Radisson Blu? Who is the purchaser? Where are the incentives going? And promptly the screen goes off because I'm... Good afternoon. Good afternoon. Yeah. I am the latest beneficiary of Linda Mama. I was going to show you the product, but I don't think IT want us to present. We have taken the hint. We shall not present, but we shall say what others don't want us to say. I'm not going to attempt to summarize what I have heard, because I have this thing that I used to hear called mom brain, and it's real, like half your neurons die. I'm not sure what I've heard all morning. A lot of buzzwords. I think strategic purchasing still means what it meant pre-delivery. The one I'm lost, and this is where I want us to start, is primary health care. Can I dare? What is primary health care? Okay, I'll present a service, and then you just yes or no if you think it is healthcare. Family planning? Yes. Vitamin supplementation? ANC profile? Postnatal care? Delivery? I'm asking. Vaginal or cesarean? Which one is primary health care? Both? Aha. Epidural? So, this cesarean was done under ketamine. How did we do the cesarean? I'm apologizing to the non-medics, but it is an important distinction. How did we do the cesarean? Did we offer anesthesia? Because it was important to control pain for the purposes of a surgery. But for vaginal delivery, whose pain is greater than a broken bone, we don't need epidural. I'm asking. Epidural, is it primary health care or not? If I use the same spinal, please note it is the same drug administered just in a different component of the spinal canal. It is bupivacaine. I either put it epidurally or subdurally. Same. The difference is I move 2 millimeters more. One is primary health care, the other one is not. I'm asking. If I offer this bupivacaine through the subdural canal, and the operation that I do on the lower abdomen is not a cesarean delivery, it is an appendicectomy, primary health care or not? Oh. What is primary health care? I have heard a lot today, like it has something to do with women's reproductive health and the products of the same. Whether it is prevention of those products or encouragement of those products. How are we deciding what is primary health care? I'm insisting because it is a fundamental issue. But then some things have remained the same. I think there's a lot of rallying around what has been decided is important. I don't know who these deciders are. Those probably the same ones who decided what universal health coverage is, are the same ones who have now told us what primary health care is, and demonized everything else that is not. I am here to be the advocate for open reduction and internal fixation of all the young men's legs that are hanging in our hospitals. Is this not a public health crisis? Is it a primary healthcare crisis? How many boda bodas do you have in this country? Oh, you're going to tell me the primary healthcare part is making sure they don't get the accident? But if they get the accident, I'm about to say that advocacy is important because we need to draw attention to especially the orphaned areas. But we can all exist. It is both and. It is not in replacement of. Because we have decided it's okay to feel pain. Epidural is not necessary. It's not primary health care. But if I deliver and have a complication, I need ICU care, is it still primary? Because I am an antenatal mother, or because I'm pregnant. If I need ICU care, I'm not pregnant, I'm not useful. This distinction seems silly in this room because we are technocrats. But in the spaces I occupy, this advocacy is detrimental to how we eventually allocate finances and what we focus on. So if people are receiving dialysis services, is it primary health care or not? Don't tell me the money we spent on mess is not primary health care, eh? I'm allowed to say these things. For a short while, we have 70 days to election. After that, I will say the things you people are saying. And when I convert, I'm going to poke just one more hole and then I stop. You know, a friend of mine recently accused us government people of praying before meetings. I'm going to quote a very famous poet. His name is Solomon. His writings are in the book of Ecclesiastes. That book is in another book we call the Bible. His poet is more famous than Tolstoy, he's more famous than Maya Angelou. So you shall allow me to quote him as a poet. It is not Christianity I am preaching to you. There is a verse in Ecclesiastes that talks about chasing the wind. Public health in general, I'll summarize all us amorphous people under public health. It just depends on which side of the stage you're sitting. Almost all arguments are correct, no? It is important that we don't hold on to this terminology so much at the detriment of other health services. Because that one individual with a lump in her breast in a level 2, when she moves to Kenyatta, we now can't say that budget cannot stay in MOH and go to Kenyatta to take care of this lady because it was only available for her when it was primary health care. When there's a board outside that says level 2. When I change that board to say level 5, it is wrong. It is not one against the other. It has to be both and. It has to be both and. I have heard a lot about purchasing arrangements. I used to know what that word meant. Let us agree that money in the healthcare system has a purpose. What is the purpose? What is the purpose of a health financing system? To purchase services. To what end? To good health. It is not to reduce out-of-pocket expenditure. Can I repeat? I'm allowed to be blasphemous. Give me 70 days. The purpose of a health financing system is what? Is to purchase good health. If you reduce out of pocket and people die, you have not utilized the health financing system. So what I want to hear is out of all these stories that we have done so well with Linda Mama, and we have, the Congolese were here recently to benchmark. I don't know if any of you met them. Colleagues from DRC Congo, there was a counterpart of mine, other counterparts from Ministry of Health, and we told them, in fact, just copy-paste. Don't even think it is excellent as it is. It is. And I'm serious, eh? And Congo has 80 million people. 20 million are under 5. 20 million are under 5 years old. They have 3 million deliveries every year. I mean, you just keep quiet in those scales. So I told them they should copy-paste it. It is perfect. It is perfect. However, I don't know, out of the number of deliveries that we did with Linda Mama, how many women died? How many died? How many had PPH? Utilization is different from outcome. And I'm actually not challenging NHIF. NHIF, I'm about to sing your praises. Wait. I'm challenging the rest of us. I get very concerned when I hear this business model approach, because the business is not to generate revenue. It is to purchase health, not health services, health. And even at facility level, a lot of the data that is housed by our maternity departments, very faithful in doing audits, right? MPPDR is what we call them. Very, very faithful. That data is never linked to Linda Mama data. Don't know why. I don't know how many of those women died. So I don't know if we spent 4 billion for the last 9 years killing women. I've said softly. I am unsure that there is a private health insurance this side of the Sahara that is more innovative than NHIF. I dare anyone to challenge the NHIF. Before NHIF said the word capitation, it was foreign language. Someone told us that about 50% of our healthcare is delivered by the private sector. True. Whatever end of the spectrum that private care is, whether it is that poster of Mganga wa Tanzania, whether it's true, whether it is over-the-counter care, whether it is some of our neighbors here. There are a few private hospitals. For those of you who have visited private facilities, and let's focus on delivery, since we have decided that is what primary health care is. Do they have a benefit package called maternity? We're talking about private health insurances. Is there a benefit package called maternity? Sasa mnanyamaza and you know, yes or no? That number is usually, 100,000, 150, depending on your provider, 200,000. Is there a copay? Do you pay over and above that money? Why? Why? If I have a cesarean over here, there is a hospital opposite Landmark Plaza. I've not said which hospital. There's a hospital there. If I have my cesarean delivery there, performed by Dr. Wala, I do not recommend. I don't remember the last time she did. And Anne has a cesarean delivery, and Liz has one, and all of them it is Wala who has done in that hospital opposite Landmark. Why does mine cost 600,000 and has 200 and has 50? Why? Pay grade, eh? How much money is circulating in the private health insurance? What were health accounts? They told us just the other day. Oh, let's start with NHIF. That one everyone knows. How much money does NHIF spend in a year? No, we are above 50 now. Msituone hivi. Eh? How much? We're but just above. Yeah? Let's call it 70, eh? How much is, sorry? 62. 62 billion. Let's take it from NHIF, 62 billion. We've said NHIF covers how many people? Roughly around 20%. How many people is that? Let's ignore all the others, inactive, some died, some paid ones, and then let's just ignore all that for now. How many people is that? About 10 million people, right? And what percentage does private sector cover? Private health insurance. 2% of the insured, or 2 of the population. 1. It's moving from 1 to 2. Let's give them 2. We are being generous. 2 even of the population, not even of the insured. What is 2% of the population? 2% of population is how many people? 1 million people. 1 million people, 10 million people. 62 billion? How much? How much? Brendan, tell them. How much? How much? How much? It's actually 50. For everything. Private health insurance is spending 50 billion on 1 million people. Because a cesarean can be 600,000, it can be 200,000. And then after saying all that, I will say it is the government's responsibility. Because it is. Regulation of the health sector is not just in the public space. And so, it is my responsibility to ask, the same way we have been asked, what are the plans towards efficiency before we even get to equity? Again, I dare the private sector that none, south of the Sahara, whichever way you decide to define it, is more innovative, not even the Rwandese, than NHIF. I dare you. Walk to Ragati Road. There's a building there, big building, have many tenants. Take an office, spend some time with the geniuses in that building. Because if there's anyone who can teach you political economy, then there's another thing people talk about, felt need. Is what is actually needed, and then there's what is felt to be needed. And apparently I have to provide both. I cannot only provide what I know is technically correct, I have to provide what is also felt to be correct. So whose feelings are the important ones? No, I mean, I don't know why you guys are keep going quiet, because as I conclude, I will tell you a story about a lady called Susan who I met actually on my birthday, on 9th September 2021. 23-year-old, she had just delivered her 6th child. Beautiful baby boy. That was the picture I was going to show you, but now IT walisema no presentation, so. She lived in, her heart, this stage is bigger than her heart. She lived with her 6 children and her blind mom. And I was maybe 20-something weeks pregnant then, and beyond youth. Apparently, we're not supposed to say age. She couldn't understand why I'm so late in her words. She actually laughed at me. Why did you wait so long? And then I told her, I didn't have someone else to finance, so nilikuwa najipanga. And then she said, it's actually true. And sitting in Susan's household with her 6 children, I was the one holding the newborn, pretending to do an assessment there. And she was with her 1.5-year-old, and then the one after was 4, and then 6, and then 8. Have they reached 6? Like that, And then I remembered that we spent so many hours chasing the wind, called targeting. You know the way Dr. Maina has told us about user fees. We remove, we return, we remove, we return. This other thing called targeting is chasing the wind, So I imagined that we were sitting, probably here in Radisson, looking for Susan with our tools, And I wondered if our tools would have found Susan. Susan, I've told you, she lived in a hut with her blind mom. She used to be married. When she left her marriage, she left with 4 children. But she has 6 now of the same man. Don't ask me, mechanics. It was a big deal to come back because dowry had been paid and her father had passed away, and where she has come back to actually belongs to her paternal uncle. She delivered in the health facility. I'm sure all of you are going to clap. All her children, save for the newborn, are malnourished. All of them. None of them had ever been to school. And she was waiting for us to finish the interview so that she can go and harvest aloe vera, which is naturally growing, scrape it off, fill a 5-liter jerry can, takes her the whole, sell that for 200 bob, and this is how she'll divide it. 100 bob for unga, 50 bob for skuma, 20 bob for sugar, because we must make black tea, kibiriti, sabuni, finished. And tomorrow the same, and the next day the same, the next day the same. So, me and, let me say Isabel, because she was in the room, and Wangia and Olago, we know ourselves, eh? We were sitting here with social protection and our friends from ThinkWell, looking for Susan with our tools, eh? Let's even assume we find her. And we go very proudly, here's your NHIF card. Go and access UHC. How many of her problems have I solved? What is PHC? I'm still asking. For Susan, and I have described to you her life. I mean, she sat, then she told me the story. I mean, she's better than Yatani in terms of dividing her money, eh? And here we are, and we've decided we are going to spend all this money and we're going to spend it on this because all these other things are not important. The rest of you find your ways to Susan's life and change her life. You're going to tell me school is free, eh? Is uniform free? Do you guys know something called NEMIS? Have you ever heard of that thing? What is NEMIS? Okay, we use it for Eduafia, but it was not made for Eduafia. What is NEMIS? Some words. But it means a unique identifier for students, eh? How much is that thing? Is it free? How much is a birth certificate? It's actually 130, just paid. Susan made 200 bob. Is she going to get a birth certificate? Is she going to pay 1,000 bob for NEMIS? Is she going to buy a uniform for the 6-year-old and the 8-year-old? Or is she just going to buy food for today? And then after we found Susan's neighbor, who has 1 chicken, and then the rest of Susan's life, we have decided Susan's neighbor is rich. Of course, she has livestock. By the way, this is a very real story. Susan's neighbor, called Helen, has a son who I don't know, fell off the tree, something. I didn't fully understand, but from what I got is that he fell off the tree and I think there was a neurovascular injury to the blood vessel and the nerves of his right lower limb. So the right limb from the hip down is basically a stick. It's skin and bone. And he's on crutches. 9-year-old boy, he fell 2 years ago. And he moves, this is Kachileba. So he has to move from there to Kapenguria, MTRH. Eh? But in MTRH, we don't offer primary health care. So Susan's neighbor has chicken and therefore was considered to be wealthier. And so Susan's neighbor, Helen, was not part of our targeting. But then they had this misfortune in their family. Now I dare say that Helen is actually more financially worse off. Their last bill at MTRH was 300,000, but he's still on crutches, and he was told, come back. What is primary health care? I've been told I have 1 minute. The rest is for alama ya dukuduku.
Thank you very much, Dr. I don't know whether you answered. You asked more questions than, but that's the purpose of reflection. I'd like to give 3 minutes to Dr. Wasuna. Dr. Wasuna is the country director for Farm Access, to also just give his reflections on the same topic, and then indulge me in the last session before we close.
Okay. Yes, good afternoon, team. Definitely it's a very interesting topic. And what I can tell you, some of these issues we were talking about here, we're talking about them in 2001 to 2009, when I was actually an advisor with the Division of Healthcare Finance. We have made strides in several areas, but we tend to be going in circles in some of them. And I would just like to give a few examples. When there was the issue about allocation to P and PHC, did we have the Ministry of Medical Services at one point? Did we also have the Ministry of Public Health Services? What was the objective of creating those two ministries? It was actually to enable P and PHC to be strengthened within that respective ministry. We have been talking about autonomy, and I think Isabella did ask that question. During that time, we had funds flowing from the national ministry to the health facility, and the government spent a lot of money to capacity build those people in those facilities. And things were running very smoothly under the PMO. Things were actually working, which really means that when you talk about autonomy, we need to unpack that word and what really we are looking for. So just to share a few things, I work for Farm Access, and our key objective is actually to make health markets work. And there are those three key actors that we look at: the patient, the buyer, and the purchaser. You know, those are, and the provider, those are the key. And we actually address the market distortions. And we have one of our prime products or project in Kisumu. Many of you have heard of the Kisumu Health Solidarity Health Cover, which is actually called MARA. So mine is not going to be asking questions, but just to give a few insights, as ThinkWell is also working with the counties. Now, before going to Farm Access, I was actually the health finance expert for the Council of Governors, and I did interact with this team, and I was actually overseeing health finance portfolio for the 47 county government. So I'll just give a few points, just in point form for the sake of time. Now, one, for us to be able to get more funds for preventive and promotive healthcare, which essentially are the services provided in level 2 and 3, we'll have to fight for capitation reimbursements. That is something which is very, very key. But what problems do we find with this? One, the patients have to be registered into a given health facility, and the patients or the community don't know. Two, you're supposed to use technology to get into the system. Think of your grandmother in the village. You are telling your grandmother to get into an app, then select a facility, and that facility is going to be where she is going to get care. It may look funny here, but that's a big barrier. What is the net result of that? Some people somewhere just capitate people. They take Mbutia here, take them this side. Take Owino, take them that side. What we have found in the Mara project is that some facilities don't get the maximum reimbursement because people around them come, they provide the services because they are free, but they don't have their records. So you provide service, but your people are not registered. And a very good example is, for example, Chulaimbo. Chulaimbo for about 2 to 3 years, in spite of the fact that it is just a few meters from the main road, it has had problems with the computer system, so they can't register people. So they provide the service, but they don't get as much in terms of reimbursement. So that's something that we need to know. Now, 2, we talk about DRM, which is domestic resource mobilization. Now, what you need to take into account is changing the legislative framework in the county is not easy. And those who have worked with them, you know how to work with the MCS. So something may be technologically sound, like an FIF bill, but depending on which side you are with the MCS, you know what I actually mean. And then there's the Public Financial Management Act. In our experience with Kisumu, we are supposed to be matching. We pay 50% for the indigent and the county pays. You know what the challenge is? The money will come in, but when it now comes to the county now contributing to the fund, then the controller of budget comes and says, where are you taking that money? Have you followed the PFM Act? Can you go and revise the Act? So those are legislative framework is very, very critical. Linda Mama, how do we incentivize providers? And just to give an example of the normal delivery, 2,500 for public health facilities, if I'm right, and 3,500 for private sector. Now the question is in strategic purchasing, what incentives are you giving? Is for the pregnant mothers to go to private health facilities. And you know what is happening in a place like Kisumu and other counties? The health workers, when it comes to almost the time of delivery, they refer patients to the private clinic to get the 3,500, and after that they discharge them to go back to the public health facilities. Again, this is actually the power of incentives. Now, we talked about the issue of data to enhance transparency and accountability. Now, at Farm Access, and I'm sure we have worked with most of you in terms of the MTBA project. Now, this really provides a solution to what we are looking at because it connects both the patient, provider, and the payer. And it also empowers them in a very, very big way, and that's something that we really need to embrace. You can see the MCA is standing, so. Yeah, I know the MCA wants, can I just say 2 or you want me to sit down? Okay, just conclude, yeah. Now, there's what is called the Master Capitator Concept, which is also an initiative within the MARWA project. And what we are trying to do with the NHIF is instead of a patient being stuck to a given facility, then they have the flexibility to move around. Again, it's a discussion we are having with the NHIF board, which is very, very important, so that we actually look at it. So lastly, with the quality. Now, one thing we need to note with the quality, in the previous regime, we had those days inspectors from the PMO's office, isn't it? But nowadays, who has the mandate of overseeing quality of health services? They are the MCS. So politicians have now come in to be able to oversee, because they move around checking whether you are doing your work. Again, between a doctor and an MCA, there are those respective conflicts. And then what we really need to ask ourselves is, do public health facilities have some incentive to provide quality services? Whether they give a 5-star or 1-star. Again, that's a question that we really need to ask. Again, under the MARWA model, we do have our safe care, which is actually used in organizations like Aga Khan, you know, and we are pushing it to the public health facilities. When we have time, we'll be able to give you more discussions on that. It has 13, algorithms, which are really very, very key and can actually be used to incentivize. Sorry about the time, but I would have talked more about it because of my passion in health financing. Thank you. But lastly, I think what we need to yeah. Now, this is very important. Now, there's this relationship between the national government and the county government. We cannot talk about strategic purchasing unless we look at the intergovernmental relation issues. Now, one, I know there are three questions. What to buy? Who makes a decision in terms of what to buy? Is it the national government or the county government? Two, from whom to buy? And let's take a case of like the commodities from KEMSA and MES. Who makes that decision? And then lastly, how to buy, which talks about incentivizing the providers. And therefore, when we are talking about strategic purchasing, Madam, it's important for us to be able to look at those three questions and then the interrelationships, because that's really very, very key. Thank you very much, and sorry.
Thank you so much, Dr. Wasuna. I attended the launch of Marwa, and indeed it's doing great work there. I had told the organizers that half a day is not enough for these conversations, but they didn't have a budget for you for 4 p.m. tea. So unfortunately, we have to stop at lunchtime. So I'd like to invite Dr. Nimala, who's going to moderate the last session, and to come on stage, Dr. Isabel Maina, Dr. Abraham Rugo, their titles are there, Oluder Odunrin, I hope I've not massacred the name, Wambugu is an apology, so we'll skip that, Brendan Kwesiga and Dr. Alamin Adan. Please come to stage. I think I need one more chair. Yeah. Okay. Yeah, like half an hour. So we have one of our guests who needs to leave. There's a photo shoot that I tried getting people to do. So please come in front. WHO, BMGF, ThinkWell, my two country directors, kindly. I think Daktari left from COG. And the representatives of the 3 counties that worked on this project. Kindly come in front for a group photo. And if you also think you need to be on this photo, I may have skipped it. It was like herding cats before tea time. So please come for the... Okay, so I think the team is there. Yes, thank you very much. That's the lovely team that's behind the success of the project. We want to appreciate you. Smile, please. Thank you. Thank you so much. Okay, so Dr. Nimala, you have the floor.
Thank you, Liz. Now, we're all talking between this room full of hungry people and their lunch. So we have to make this interesting, short but interesting. So thank you all for joining. Dr. Maina, you started off the day with this incredibly useful overview of the sector and health financing status as of today. And you talked about the increase in the public share of total spending, the share of the share of the government budget that's going for health, and indeed counties are allocating more money towards health. But I was curious, you talked a little bit about the changes in the conditional grant system, which seems to be the main mechanism through which the national government can influence county allocations for primary health care. With that gone now, what are the ways in which the national government can incentivize greater expenditure in primary health care? Now, of course, Wangari has challenged us all, what is primary health care? So at least for the purposes of this discussion, investments by the county in level 2 and level 3 facilities, what's happening right now, and what's the role of Ministry of Health in ensuring that more resources are flowing to that level?
Okay, so thank you very much. So in the morning we talked about the changes, but just to clarify, it's just the change in terms of moving from one pool into the next one. I see faces. The next one means from the national government pool to the county pool. Because what happened is that since 2013, we've had this conditional grant user fee forgone that was under the national government to fund level 2 and 3. But then for this financial year, that was put into the equitable share at the county level. Now, so that now the counties can allocate to the level, primary healthcare, whatever primary healthcare is. When I interact with them, tell me what primary is not, but they have never told me what it is. So anyway, that's by the way. So what is the role of national government to ensure that, things are happening down there? So constitutionally, the national government is in charge of guidelines and standards, as you saw. And one of the things, as I think Dr. Owino has said, is to work through the intergovernmental mechanism to ensure that such guidelines are cascaded down to the county government. For example, the primary health care, the community health strategy, and all that. Number 2 is that as much as we do not have conditional grant to the lower level, in the implementation of universal health coverage, we've been entering in what we call the intergovernmental participation agreement with the counties, for example, where we agree that, for example, if national government is to invest in supporting the community health services, for example, training, then the county government would, for example, put some incentives in terms of incentivizing the community health workers. So we do have some frameworks for that. National government does not work in isolation with our parastatals, NHIF, and we are working on mechanism to ensure that also reimbursement to the lower level facilities is also attached to quality of health services. So that means also national government supporting the counties in terms of data systems, in terms of communication and all that, based on our role as that is constitutional. Thank you.
Thank you so much. Brendan, I wanted to throw this question to you next. I know you and other colleagues from WHO have done a lot of work on this intergovernmental financing systems. What do you see as some of the biggest threats to the health sector as money moves into the equitable share? Is there some risk that it's a big win for the counties, but is there a risk for the health sector?
Thanks very much. I'm hoping you didn't get to me because Isabella throwing jibes. So usually I want to start from my point of positivism, then I can move to the risk. For most of the speakers, all we have been saying devolution works. We have seen what has been able to do. And of course, one would imagine that if counties are given more autonomy over resources, then even better results will be observed. But of course, what are the potential risks? So even before this change where the conditional grants were put into the equitable share, we knew that there was a challenge in terms of money being allocated to the facilities, it being able to flow there, it being able to flow on time. So if I'm to emphasize what I see as the risks is the ability for now those facilities to be adequately funded and getting that money when they need it. Now, most of the discussions we've been having here around facility autonomy, around ability for facilities to claim especially, maybe potentially could help solve that problem. So again, I would go to my positivist self and say, we know county governments serve the interests of the facilities at heart. Of course, they want the facilities to serve the people. So if they are able to now allocate money to them, but also enable them to receive and utilize their funds, then probably would then solve that risk around their ability to get money allocated to them and for the money to flow to them on time. So I think that's how you try and operationalize, because Isabella spoke from a position of mandate. I'm speaking from a position of norm. I'm sure there's someone speak from a position of practice.
So actually, maybe I'll go to Dr. Alamin. From the position of practice, you're in the Isiolo County government. How are you now thinking about the pot of money that you're getting from the national government, ensuring that enough flows to level 2 and 3 facilities? You're no longer required by any of these conditional grants from DANIDA or user fee foregone to ensure that that money goes there. So are there competing demands on that money, and how are you protecting that money for PHC?
Okay, that's a very good and difficult question, considering the current social political circumstances that exist within the counties. But basically on the upside is the fact that we are now moving to a hybrid system that is more of a partly social insurance-based scheme and partly tax-based schemes. So depending on how that is split, in terms of if you now take the current context of Isiolo County, the healthcare workers, the infrastructure development, the commodities are all supported through a tax-based scheme that has been working. But it's the other operational components that are really suffering, most of which in primary healthcare were purely almost 100% supported through DANIDA, that is level 2 facilities and level 3. So now what we are hoping is that for Isiolo, we did establish a FIF bill, and fortunately implementing has become another elephant in the room. It's another difficult hurdle to tackle, how to implement in the devolved systems, but it's something that we have been working on, and we are hoping that we'll be able to roll out quickly. Through that and achieving the semi-autonomous state of these facilities, we are hoping that they'll be able to generate adequate funds and run them within those facilities, as well as try and establish a matching fund, like a grant from the county government, which again is pegged on the political and the social environment within the county, but it's something that we are, from the department, have already proposed to the executives and see how it moves forward.
Thank you so much. I wanted to go to you next, Rugo. I know IBP Kenya has done a lot of work around participatory budgeting and downward accountability as well. What is the role for civil society and advocacy to ensure at the county level that more resources are being budgeted for and then being spent on primary health care?
Thank you so much. One is to appreciate that because we adopted for ourselves a participatory devolved system, in other words, citizens have a right and an obligation to participate both in national government decisions and county government decisions. There's a space in there of enhancing and facilitating deliberation. Now, one of the things that sometimes we get lost is the fact that health is not the only demand on public finances. It's one of the demands. And one of the jobs that has become quite an interesting one, particularly for civil society, is how then do you facilitate a process where citizens are able to participate, are able to contribute in what should be priority in their areas. So that is, for instance, moving away from brick and mortar kind of priorities and saying, in some places, you actually have an excess of health facilities in terms of infrastructure. What you need is a nurse. What you need is, essential supplies. What you need is water connection, because we know dispensaries that don't run because simply there is no water. The nurse is there, from morning to evening, but there's no water, and therefore she has to close the facility because. So I think it's supporting that process of deliberation of saying, what is the actual priority? But a second one is we also put ourselves a structure we call the county assembly. We may have different perspectives as to why they are there and what the role they play, but the fact is they are the ones who finally make the final decision on how much money goes into services. But where we are finding there's more work, we are doing a lot of work around that as IBP together with our partners, is that whereas there's a lot of emphasis on allocating, and MCAs are very keen about even projects that are visible for the politics and the optics of it at the ground level, there's very little emphasis and push on implementation. What exactly is going on after we allocate all this money? So therefore I see a role for civil society in that deliberation in terms of what are our priorities, but secondly, in terms of following up on what is the actual implementation of this spending, and perhaps to push the conversation further, even against some of our political leaders who just want more and more capital projects, brick and mortar because of rent seeking. To actually what we need here is a nurse. What we need here is water. What we need here is what actually actualizes the service, as it were. Thanks.
Thanks so much. And that emphasis on monitoring implementation, I think, is a good segue to the next set of questions I wanted to ask, which is about Linda Mama. We've talked a lot about the Linda Mama program, and indeed, any conversation about health financing and strategic purchasing in Kenya, it's hard to avoid talking about NHIF. So I'm going to put you in the hot seat now a little bit, Marie, just to share some reflections on what we've heard about the Linda Mama program, the implementation challenges that the program has faced, not only because Linda Mama is an important program, which it certainly is, but NHIF's role as purchaser is going to be even more pronounced under Afya Care, the main vehicle for UHC. So some of these challenges about beneficiaries not knowing what their services are, which we heard from Stacey, the money not flowing to facilities. How is NHIF proactively tracking the implementation of schemes like Linda Mama and Afya Care and addressing these kinds of implementation challenges?
Okay, thank you very much. I'll acknowledge, of course, when you're starting up a benefit package that initially was not with you internally, and it's being brought to you as an institution to take it up and develop strategies of how to make it more effective, sustainable, and user-friendly to all. A lot has been taken up, starting with the focus on the three main body parts of UHC in health financing. It begins also with the definition of the package. Yes, it was with the ministry. Ministry brought it to us based on the capacity we have in terms of financing and based on the previous history. But much as it was brought, how do we try and improve it to make it better? And I would acknowledge, of course, there are teething problems, but through that user focus and leadership and support, again, from Ministry of Health, at the same time with NHIF leadership management, whereby we are able to integrate some of these challenges on once in a while. We have those quarterly meetings just to review those gaps and see how to improve on some services within the Linda Mama benefit, because remember initially it was just on the normal delivery alone. But the other complex issues that came in as we are continuing in comparison with the normal maternity benefit package NHIF has. So out of that, we are able to pick up those teething problems through our utilization reports, share with them. They give us recommendations. We also give them recommendations, and we see how best to improve on it. The other aspect is aligning also those benefits on the quality package in terms of aspects of quality assessments, using the overall KQMA checklist, you had my brother talk so much about it. Joint inspection checklist from the KMPDC. And of course, NHIF, we also have our own internally, just to align most of those benefit package. And you see, out of that, it also enables us in terms of easier way of monitoring the claims, the quality of claims which are brought on us, because we don't want also to put our members into risks. Remember, they've entrusted us with their fundings. The aspect of quality assessments, even there's one we did recently, I think it was in October last year, and we involved all the stakeholders, the KMPDC, the Ministry of Health, and they're able also to see, based on even CAFing level, how they normally do it, which also has an impact in terms of strategic purchasing. Remember, our rates are based on the CAF's level. And you'll realize by involving them, they also own the process, they acknowledge, and we're able to address those quality gaps. Of course, the aspect of on-site investigations through our quality assurance within the institution, who are aligned within the respective branches in our countries. There are about 105, and they're able to help even the facility through quality improvement team programs, health assessments, investigations, clinical audits, even with the claims being brought on board prior to us making those payments. So out of that, you'll realize much has been done, but it's still not enough, and there has to be some form of continuity in how we improve those aspects. And yeah, I'll acknowledge we've gotten very good support from ministry and relevant stakeholders. Thank you.
Thank you so much. And here I wanted to, of course, much of this discussion today has been so focused on Kenya, but my colleague Oludare, you're working through the Spark project on purchasing reforms in other countries all across Africa. And so these challenges, for example, that NHIF is trying to address and learn, I wondered if you had some lessons to offer from other countries that have made this journey, are making this journey. An agency like NHIF, both in terms of monitoring and routinely improving the program and in terms of governance, are there lessons that Kenya could learn from other countries?
So, thanks, Nevala. I think for me, the first place to start, and I will just say this and move on, is that we have to remember always that there is no conversation we have that is valid once it loses direct, please, I'm picking my words very clearly, direct emphasis on the beneficiary. Like I said, I'm picking my words specifically. What I find out is that many times we sit in rooms like this, and I'm very, I feel sad when Gary has left. But I find out that many times we sit in rooms like this, and when I started out as, in this space, that was my biggest shock. I came into the NGO space because I wanted to help people. I was passionate that people could get health. But I spent my first 3 years in this space, and I literally took a count of the number of meetings I attended with Ministry of Health, with partners, and things like that, and how many times we ever passed by the number of people, the number of pregnant women that die at birth, and all that. And do you know what my count is? 0. The only time it shows up again is when we want to write a blog, a post, and then we start with that introduction. Maternal mortality is a problem in Africa. But in our conversation right here, it's all at the top level. So I think I want to start with that. And why have I started with that? Is that what I have seen, or what we have seen rather as we gather, is that a couple of countries that seems to have, taken some strides and been deliberate is because the motivation comes from the fact that the beneficiary is key. And why am I saying that? We have talked about facility autonomy, we have talked about intergovernmental relationships and things like that. One thing we have seen, and this is evident even in Kenya, I think Kenya has made a bit of stride in that area, Ghana, Rwanda, is that the motivation comes from the fact that the political class do not see health financing or UHC as just a procurement issue, but a political issue. And how is it a political issue? Because these two subjects speak about the same game. It is the game of numbers, and those numbers are the population. So, in Rwanda, for instance, it is difficult for you. I mean, and we're going through a process. We're working with Rwanda right now. And they tell us, look, this reform has to be done by the end of the year. Partners or not. Why? Because there is going to be a retreat at the end of the year where the president is going to ask every discrete person, what is the level of coverage in your community? So whether the Ministry of Health likes it or not, they need to deliver, otherwise all hell is breaking loose. What we have also seen is that similar to, especially in devolved environments like Kenya, Nigeria, Ethiopia, is that intergovernmental relationships can be difficult, and there could be duplications also across that, especially monitoring and things like that. But then, you know, a lot of collaboration has to be in place. A lot of collaboration, a lot of joint learning, a lot of positioning the national body more like an advisor and not just an enforcer. Because, and you know, I would say this probably to a couple of people from counties, and maybe generally to us. Devolution is good, but we also need to be careful to the extent it goes. And an example is Nigeria, where you have now had 37 separate, unconnected health insurance pools, because they are the states are fully autonomous. The states have the right to say they want to create their own local government or sub-county levels. The worst the national government can do is, okay, we're not going to award allocation to you. And we had seen a state that has happened, and the government punished them for 9 years. And in those 9 years, they became the 5th largest economy in Africa. So could we say it has worked in their favor? Now, so why am I saying this? I think that Kenya is still at a safe place where there is still that collaboration. But what will push Kenya off the cliff to the extent of Nigeria is where the national government thinks that legislation is the only way to pass down policies. If that happens, county will begin to enforce and increase their autonomy to be able to feel free. So there has to be a collaboration. There has to be an advisory partnership. And for instance, in Nigeria, one of the conversations we have been having now is to position the national body not as a regulator, but as a technical assistant to the states, where they are able to provide that guidance as they go on. Finally, we mentioned facility autonomy, and that's in our mapping exercise across the 9 countries. That's something that came out very strongly. And no doubt, facility autonomy is the way to go. The evidence is there. Same way we talk about capitation, that is the way to go. But have we also found out that the evidence have also shown that there is a lot of pushback on those two terms? So we need to go back and gather more evidence of why. We know that the evidence says yes, but there's another side of evidence that says no. So what's in between? And there are a few factors. For facility autonomy, number one is the fact that politics is a game of power. Nobody wants to lose it if they've had it first. Number two, so as you think about what is right, we need to communicate what is right in the interest of what is feared. So how do we ensure that we are communicating to these people who have held that power? And when I say power, I'm not just talking about authority. Financial power is very important. Who have held that power in a way that they see that losing power is actually to my advantage. That's one. Number two, we need to de-nomenclatize, if that English is correct, a lot of things. Move from naming to objectives. The objective of facility autonomy is what we should focus on than the term. And as we have heard here, that term, and you see, again, the reason why I say that is that the public space, the public sector works on nomenclatures. And the nomenclatures have a Jenga. It is defined. If I come to Dr. Isabel and I say I am doing a curriculum, it doesn't mean the same thing as a training. It is clearly defined in the public sector dictionary. So when you go to the Ministry of Finance and you say autonomy, they have a dictionary meaning in their term as autonomy. Forget about what you defined it when you are doing your research. And that is the way they are going to paint it. So we need to be sensitive of what is there. Number three, and I'm going to stop here, is financial management capacity at the facilities. If we're talking about financial autonomy, of course, not underscoring the fact that a lot has been said about keeping accountability, but do the facilities have the capacity for one, allocative efficiency, for two, technical efficiency? Do they have the technical capacity to be able to say, this is where my needs are, and this is where I should spend that money? And the biggest example is when we look at drugs. A lot of times where financial autonomy has been faulted has always been in supply chain. Because quantification capacity for inventory management is zero. I personally manage a project where I saw that clearly. You know, you have drugs that are on the shelf that are expired and nobody's saying anything. And, you know, for several reasons. So those are just a few thoughts that we've seen across countries that could be helpful.
Thank you so much. That was comprehensive. Here, I'm going to check with our MC. Do we have time? Okay, 5 minutes. All right. So then I want to move to this really fascinating discussion that you've already introduced, which is around facility autonomy. We've talked about it many, many times. It's come out in many presentations. But Dr. Maina, as you correctly challenged the room earlier, it's easy to say, oh, it should be autonomy, and as you just reminded, the facilities need to have capacity, and are we now setting them up a level 2 and level 3 facility? Are our expectations that they'll be able to account for funds the way a hospital does? So I wanted to now get a quick round of responses from all of you, because I know you each have a perspective on this from your different vantage point. Ministry of Health, what is your recommendation? Rugo, as a PFM expert, what would you advise? What's a more realistic expectation in terms of facility autonomy and accountability in particular? Brendan, I know this is a question that you've worked on a lot, and you're also working in a lot of different counties. What are some emerging challenges? Daktari, how is Isiolo thinking about it? It's taken you a long time to go from 1 facility to 11 facilities being able to submit claims to NHIF. So now, what does the future hold? How are you thinking about speeding this up? NHIF, what is your perspective on this? How are you helping facilities to build more capacity to submit claims? And then I will give you the last word, since you brought up this really important question. So just to speed things up, Dr. Maina.
Okay, so thank you very much for the very hard question. But let me start by saying how the main discussion on facility autonomy started or was activated or catalyzed was because of the issue of flow of funds. From the lessons from the pilots, after devolution, we have this issue. Some counties, the money doesn't flow to the health facility level, and we thought, you know, before devolution, I think the districts and facilities had some level of autonomy, quote unquote, some level of decision-making, planning, management, and all that. And as he said, sometimes we think legal, so we have the PFM Act, and it's because of the CRF, so we did engage Treasury, the Attorney General, but that route is a no-go zone for now. So what we have done, and is constitutional, is apart from legal, we have what we call the 4 C's in the Constitution. We have to work on the basis of collaboration, consensus building, and another one. Consultation and cooperation. Well, there's another C. Some of them are similar. But, well, we have 4 C's. At least I'm sure of collaboration, consultation, and consensus building. Look at the Constitution for the other one. But basically what it means is that even as we talk of legal, we engage with the counties. And what we are doing is to support the counties through sort of assist them to ring fence the health funds. Some want to ring fence at the county level through what they call the county health fund. Some would want to ring fence at the facility level. But I like what he has said. The end result is to look at what are the finances meant for. So what we have done also is to try, as we work with them on the FIF guidelines and ring fencing, we are also trying to pick best lessons from different counties to look at those who are implementing, even without the law, even without the county-specific laws, because some of them have passed, but yet money is not flowing, to look at lessons and the outcomes that are related to good financing at the health facility. Just recently, Isiolo County was in Nakuru just to pick lessons, and they actually, maybe he can comment on that for purposes of the other counties who are here. They learned good lessons to ensure that now when they go home, they'll be implementing. So this is what we are doing, trying to get best lessons from the counties, peer learning, that consensus, and of course, as we work on the guidelines. Yeah, thank you.
Perfect. Thanks. And so now, Rugo, you've looked at other sectors, not just health, and you've seen whether this autonomy thing, this animal, is a good thing or not. So any words of wisdom or caution as the health sector folks try to push for more facility autonomy?
I think it's important for us to appreciate that because of the kind of infrastructure we've put ourselves into, you know, a constitution that is participatory, that it has all these stakeholders, but it's also that is largely driven by public resources. We are going to find ourselves in more and more situations where control and accountability is demanded of these resources. So I don't think we can run away from that. You know, we will be required more and more to account for how these resources are spent. But there's a good side to that. The good side is that it is no longer the 20,000 you used to collect at the facility. You actually have more resources. And sometimes I think if we limit, facility autonomy around the conversation around just the facility improvement fund and the committee that pays the work, sometimes we miss it because there's bigger, and that's why I was talking about the comprehensive functions that a health facility is supposed to deliver. If we tied the discussion around that this is what they are supposed to deliver, these are the performance indicators for this particular facility, it is very easy to capture the language of autonomy by saying, we've agreed this is what you must do. Now, and then of course, because we are providing a huge part of the public finance, of the resources through the public financing, then the resources, of course, there's a discussion about the flow of funds and how timely they are. Then it becomes very easy to be able to make an agreement, almost a performance contract of sorts, that involves the citizens benefiting from that service, the persons responsible, and the county government that is supposed to ultimately, because the governor, at the end of the day, if there's no health services being provided in a certain health center, it's the governor responsible. I mean, he's the person people go marching to. I have seen that in Busia, I've seen that in Baringo, and many other counties. People march to the governor's house or to the office, wherever they can find him, and say, our facility is. So I'm thinking of organizing the whole discussion around an objective that is slightly bigger than just the small resources that used to be available for the running, of the facility. There are drugs, there is a timeliness of the nurse, there is how quick you get a service, and that whole discussion. Part of it is going back to the service charters. They sound very simple, but perhaps that's, for me, I think that's what will be my take. But we are not going to run away from the PFM boundaries, because we are largely becoming public funded, and with public funds, there's going to be more demand of how much accountability we need to provide for these services. Thank you.
Thanks very much, Abraham, because I think I would love to pick up from there and also use my, Dario was supposed to give examples from very many countries. He spoke of the good, but the bad he picked from Nigeria. So I can be allowed to pick the bad from where I come from. So I'm from Uganda, and facilities do have autonomy, but then I'm trying to run out from that word autonomy to make choice by talking they have decision-making power. Now, decision-making power over what? Because that's the discussion we're having, like, what should facilities be allowed to make decisions about? Now, everything is linked, and to give an example, just building on what Abraham was giving, for instance, I think as with this, when we were discussing with Nakuru, the CEC was saying, I don't have to keep a specialist in my hospital seated. They come, they provide the service, I pay them, and they go. And the service is, you're able to access the service, it is more efficient for you, like you don't keep someone you're not paying, and the system functions. So beyond us now being able to throw the word autonomy, PFM is constraining, what do we want to make the decisions about? Now, the bad example I was supposed to give about that, my country, is I see all facilities, first of all, they are getting very little money, and the little money is now, the decision making is about how to share it among the management committee, because it is very little to do anything at the facility. So you may say, let money flow, let money come and make decisions. So it's about how much are you going to share this time around? Full stop. And at times the health sector, we get into a dilemma when we are saying, let's speak the finance language, and we speak the finance language and forget to speak our language. So we want to make decisions, yes, about what? And once we now have very clear things about the decisions we want to make, for instance, I'm sure if we say, we are paying this consultant so much, this is because of this and this. The usual example we give is cleaning the compound. The governor shouldn't really determine who cleans my compound. So such aspects. So I think once we have some clarity around what decisions we want to make, then we'll stop using the word autonomy, and Dr. Maina will stop asking us to say autonomy for what, because we'll be clear about what we want to achieve. So I think for me that's my key message around the framing, because as I conclude, when I came here some years back and I was told facilities don't receive money, I was like, so a facility does not receive money and operates and it functions. But then I was like, hey, but I know facilities should receive money and they don't function. so it's not just looking at opposites and thinking, because this is not like me, then it works. So let's have some clarity about what we want to achieve with these autonomies so that we can then advance the discussion better. Thank you.
Thank you so much. That's a really great word of caution to not just run after one silver bullet called autonomy, but place it within a bigger framing of performance and performance management and facility management. So all of these are, of course, very technical considerations. You're dealing with the active politics at the county level, and as you said, there was this big white elephant of implementation of the facility autonomy legislation, which I'm sure looks beautiful, it's passed. So what's stopping Isiolo, or what are some of those challenges? If you can speak candidly, please share with us. What does that journey look like for Isiolo?
Yes, as you've rightly put it, we have the legislation in place, and I actually thought once you have the legislation, there's nothing to stop us. We've done it, it's done, it's over. But there's a lot of issues that are coming up. As was put forward, the management capacity of these level 2 and level 3 facilities, especially if you look at the level 2 facilities, most of them are manned by 2 healthcare workers who are mostly nurses, barely any training in financial management. So basically all they have is the nursing skills to render services. So that does not, it puts them in a difficult position in terms of ensuring efficiencies and how effective these funds can be in the expenditure. Also, again, for our county, if you look at most of those nurses, they are fairly new. These are nurses who've come in the last 5 years of government. They're young, they're inexperienced, they're new. Keep putting them in that position, it makes it difficult for them. I don't know if I'm expressing myself well, that they're not in the best position to manage these facilities. And these are the discussions that are coming up. But in Isiolo, we have acknowledged that there is need to increase purchasing of primary healthcare. We've also acknowledged that there is the only way we can achieve that is by increasing the allocation to primary healthcare. And we finally acknowledge that there is also need to protect those funds and ensure that it gets right there where it's needed in those facilities. And all efforts right now are on how to get that implemented.
Fantastic. So then, Marie, I'm going to come back to you, and reflecting on this conversation and this emphasis from autonomy to performance management, that calls for data.
Yes.
How much is NHIF paying to each one of these facilities? How many claims were submitted? How much did they pay out? Many of our colleagues have gone and collected that information through surveys, but you have that information in your machines. So what can these good folks expect from NHIF in terms of reporting out of this very critical performance data? And I heard Dr. Maina remind you during one of the breaks that MOH sits on the board of NHIF, and you're the boss. So what is MOH doing to ensure that this data comes out of NHIF? So over to you.
Okay. I may not have all the accurate answers on how much we've paid this financial year, but we've put several aspects or processes in place in a way that we try to simplify the whole process of reimbursements and ensuring our members get quality of service. First and foremost, by looking on the past, how are we doing it? What were the challenges that we had in the past? I'll give a good example, like on issues of contracts, whereby you'll realize we were giving basically to the facilities from level 2 up to level 6 upwards, but it reaches to a point whereby at the level 2 facility, there are some decisions they cannot make because they are dependent to the main county government. So out of that, it was a determinant that much as we are doing the bottom-up approach towards reimbursement, we have to do both model of centralization and decentralization approach in terms of how we support these facilities, right from the county government at the policy level, pick up issues which are raised through stakeholders and engagements, because we do quite a lot of them, by getting feedback both from the managed schemes cover and the national scheme cover. We normally get a lot of complaints. So out of that, we build those complaints. What is applicable with the ministry, we share with them through the feedback of what we've gotten, including the research like the one she has talked about. And what is applicable to other relevant body through ministry like Council of Governors, we bring them on board and tell them, look, this is the issue. Payments are being done, but the challenge is this payment, much as we are paying them, and there's evidence that we've actually paid this money, it's not reaching back to the facility point of view so that it's a revolving fund to help in terms of giving quality healthcare services. So how do we go about it? So out of that, with the determinant of the feedback we get from the ground, some decisions to some extent, I must acknowledge Ministry of Health have been of great immense support to us. And that is how the FIF came about, because the money may be there, yes, but if it's not going back for its main purpose in terms of giving that health, then it's as good as not giving money. Yeah. Then the other aspect, of course, is through capacity building and support. We are over 156 branches across the country, and each branch is aligned with the facilities. So you'll realize our systems are also integrated in a way that even at the branch facility, they're able to reach out to those facilities within the localities in terms of supporting them towards training, like the current changes we've done on the model of paying, the e-claim model. We have technical people from the ground supporting them. Where there's a teething problem, they're able to communicate. And also just have good interpersonal relationship. That is all that counts. And out of that, we've seen quite a lot of changes in terms of even when we were transitioning. I must acknowledge it wasn't easy, but with that good rapport and relationship for them to understand where we are coming from, at least it has also helped. And then on top of that, we also do a lot of stakeholders engagement through communications, a lot of researches, just to get to have the feel what is on the ground. And then based on that, how do we focus more on the user focus areas where the gaps have been notified? And of course, look at the available resource within us. Then how do we modify? If it's minimal, how do we modify the minimal resource we have to make it more better than how the situation is at the ground, and for purpose of sustainability of healthcare financing. Thank you.
So in other words, you're going to make more data available to everybody, is what I'm hearing?
Of course, the data is also is always available based on the needs and requirements, and you'll realize even the benefit packages we've constantly been adding or rolling out, the determinant is based on the data we get, the utilization, the notifications. That gives us now guide, like maybe, okay, now we need to have an oncology package. There's rise on cancer, so yes.
And Dr. Maina, you'll use your role on the board to ensure there's more visibility on utilization data, on claims data, etc.
Thank you.
Okay. Yes, I'll use. But let me say this. I think data is available in Kenya, and this is not just NHIF. Yes. Data is available. The issue is where, as he's asking. If you go to the community level, data is there. If you go to level 1, 2, 3, data is there, including who sought services, including who delivered, including who sought whatever service for fee for, Now the main issue, and this is what the system is working on, is integration. So that then that data there's a bit of integration, Most of our hospitals, for example, have EMRs, but that is now at that facility level. If you go to NHIF, they'll even tell you which facility is claiming what, who is claiming the highest. For example, you saw in the newspaper last time, looking at even public facilities now surpassing the private facilities. But now what we need to work on is integration of that data so that NHIF is integrated with the providers. That is also integrated with our district health information system, the DHIS. So data is there, the problem is fragmentation. Number 2, data is there, it is the use. So more often than not, we are using it in research. We present in, where are we? Radisson Blue, and then go home. We are not presenting to the beneficiary that he talked about. So if we can break it down so that we go to Wanjiko, beneficiaries in Kenya, we call them Wanjiko, for those who don't know. If we go to them and, show them the utilization and all. So data is there. I think we just need to improve on, and I'll say this because I can see we are closing, that I think let's not beat ourselves so much. We have done so much as a country, as stakeholders, but more often than not, we concentrate on that last slide, the gaps. Yeah. And then we forget that we have made some journey, and then we bog ourselves down on that slide instead of looking forward. I would say this as I close so that you don't ask me again, that we have the foundation now. I think it's only now moving to actualize the journey. We have the systems, we have the frameworks, we have we have stakeholders and good relationship with all stakeholders, intergovernmental forum, we have the structures in place. So let's take off. Thank you.
Fantastic. Thank you so much. So then just to quickly summarize 3 key messages, and I'll start, Dr. Maina, with your final point, that we do indeed have a really strong foundation in Kenya of amazing programs, legislation that counties have passed, programs and policies at the national level. And so now we're in the process of improving the implementation. And so let's not just focus on the glass half empty, but also half full, and continue in this journey. I think my good friend Oludare mentioned how we need to keep in mind the final beneficiaries in this whole journey. And indeed that links, Rugo, to your point about bringing communities and civil society along this journey. It's not just about folks sitting in big rooms like this, but whether it's decision-making or accountability, that it starts at the community level. And finally, I think a great message from this discussion, which is let's not focus blindly on autonomy, but couch it within a bigger discussion about performance management, capacity building at the facility level, and improved accountability at the facility level. So let's wrap up there, and I'll call my good friend Anne to give a final vote of thanks, and then we, I think, break for lunch.
Thank you. Thank you so much, panelists. You may have your seats. Unfortunately, we're pressed for time. Please come for a group photo. Yes, common group photo, and then there's some rewards. But I want to thank you for holding 1 extra hour, but we are now winding up. And with that, I'd like to invite Dr. Anne Musova to close up. Thank you very much, and receive our tokens of appreciation for taking the time.
I trust I can still be seen. Mine will really be very brief. It's really to give a vote of thanks. First, I just want to thank you all for making time this morning, getting into the afternoon, sparing your whole half a day, and we've extended quite a bit. It's almost lunchtime. So I really appreciate that. I don't take it for granted. The objective of our day today was really to pause and reflect on the progress of strategic purchasing and financing for primary healthcare in Kenya. And I really hope that we've gotten some good reflections, discussions, but it's also left us with some questions and food for thought as to, even as we continue working in the next 4 years, 5 years, what should the interventions look like? What should we be focusing on? I'd like to thank very much the panelists and our speakers who have been here, especially the panel that has just left the stage. I'd like to thank Dr. Wala. I think you've been an excellent MC. I like the issue, just start standing when someone was running out of time.
sending a very clear message. I'd really like to thank the Ministry of Health. We have here Dr. Isabel, I could see Dr. Salim, the Council of Governors, the UHC Secretariat, our county colleagues here, the county directors of health and other CHMT members from the various counties that we work with, Isiolo, Kakamega, Kilifi, and Makueni. I can also see NHIF representatives. We have Marie, but we also have our NHIF representative from Isiolo. Thank you very much for joining us, but also for the collaboration and leadership that you've given unto us as we implemented this project for the past 5 years. I'd like also to thank the Bill and Melinda Gates Foundation in absentia for the investment in Kenya's UHC journey and in partnering with ThinkWell over the past few years. I'd like to thank our partners, Kemri Wellcome Trust. I think we've worked very well together, and the insights that you've provided had really provided evidence for the country to improve strategic purchasing. For other partners, the WHO, Brendan, Spark, International Budget Partnership, and Jacaranda Health, that we partner on many other things. Asanteni sana. Nirmala has been the project director for the strategic purchasing for primary healthcare project for the past 5 years. I think you've done a stellar job of starting off this project, thinking through interventions in 5 countries, and also thinking through the phase and design of the next phase of the project. So I think on behalf of the entire ThinkWell team and our partners, I'd like to thank you for your amazing leadership over the past 5 years. Yes. A round of applause for Nimala. Thank you very much. And karibu sana to Matt, who's also been the Deputy Project Director and will be taking over from Nirmala. And finally, I'd like to thank my team that has made all this work possible. My county colleagues that have led our work in all the counties, Shano, Geraldine, Daniel, yeah, there you are, and Felix, who has also supported the work in Makueni County, Boniface, who's really helped marshal everyone together. Finally, I'd really like to thank Janet and Alice, who've really planned all the logistics around today and just making sure that everything goes smoothly together with the Consolata. So without further ado, I think we'll close the meeting at this point. Welcome you all to lunch. We received apologies from the Chief Administrative Secretary, Dr. Mercy Mwangari. She just came from Geneva the day before yesterday at night, and she fell ill. She wasn't able to join us today. She thought she might be able to make remarks towards the end, but she really was not in a position to. So please accept her apologies, but she was with us in spirit. Asanteni sana, and welcome for lunch.
Thank you. Lunch is served. As you go out to your left, you'll see the restaurant. You have your vouchers. Please carry them with you. Thank you.
The Facility Improvement Fund, FIF, is revenue collected at public health facilities as user fees paid to defray the costs of running these facilities. This fund is vital in enabling facilities to manage their day-to-day expenses and manage situations where emergency supplies have to be acquired. Facility Improvement Fund is one of the key areas that ThinkWell and Kemri Wellcome Trust are working to improve in the purchasing arrangements for primary healthcare services under the Strategic Purchasing for Primary Healthcare SP4PHC program.
Purchasing is strategic if decisions about the allocation of funds is based on information about provider behavior and population health needs in order to maximize health system goals. In Kenya, we have various purchasers. We have the Ministry of Health, the National Health Insurance Fund, and counties.
Before devolution, the health sector was one of the most decentralized, with a lot of decision making being at the subnational level. Of course, a lot of guidance also from the central level. With the devolution, we've seen also that sort of health is one of the most devolved, with the decision making at at the decentralized level or the devolved levels.
What ThinkWell has been doing over the years is to help counties appreciate that you could retain these resources at the health facilities as you still ensure that accountability structures are maintained to ensure that Treasury is still able to have a clear understanding of the volume and the trends within the collections of these funds at the health facilities.
The fact that the autonomy gives them that decision-making role enables them to be more efficient. The teams within the facilities are more accountable. They are more motivated to perform. So all this motivation, good control, the efficiency is expected to lead to improved health outcomes, as indicated by the health indices. So you see improvement in the health status of Kenyans because of efficient service delivery at the health facility level.
Work that we've been able to pursue with the county is supporting the county to develop regulations for the facility improvement funding, which gives a guideline or a mechanism for how monies raised within facilities can be used to improve quality of services.
PFM Act requires Section 109. All the monies that are generated in the county are swept to the CRF, County Revenue Fund. But the exemptions under the same Section 109, which allow counties to actually make laws within their county assemblies that exempts such institutions from sweeping the money. And Makueni County in the year 2017, through the County Assembly then, passed Makueni Health Services Act, and it clearly allows that all our hospitals, the level 4 hospitals, which have been collecting revenue, to retain that money within their bank accounts and to expend that money for purposes of defraying expenses at that level. ThinkWell has really worked with us. We have worked with them very closely to formulate regulations that support that act.
You know, initially, the monies that we used to collect used to go to the county revenue account, then they go to the national treasury, and it will there will be delays in disbursement. And that meant that we'll have periods of stockouts, and also the quality of services that we'll offer to our mothers were a bit wanting. Since the start of this financial year, the monies no longer go to the county revenue account, so the turnaround time for the disbursement to the expenditure account in the facilities has really helped greatly a lot.
The Facility Improvement Fund in Isiolo fairly stopped because Isiolo is one of the pilot UHC counties. So with the introduction of the UHC as a Big Four agenda, number 4, the services were made all free. Because that is a pilot project and it is stopped after 1 year, then what will happen after the project stops? So therefore, we met and started introducing an idea of the previous user fee, but in form of Facility Improvement Fund. How shall we be able to fund our services so that we'll keep the quality of healthcare delivery to the standard that is required?
Public health facilities are important players in implementation of key policies like universal health coverage. And it is important that we safeguard their autonomy through application of the correct form of legislations at the county level.